increase in BNP, or you have clinical evidence of pulmonary or systemic venous condition. So you have to have symptoms and signs of heart failure like pedal edema, heart failure, symptoms like dyspnea, PND, and so on, or you have elevated BNP. Now the heart failure is classified according to ejection fraction. Less than 40 is reduced ejection fraction. 41 to 49 is mildly reduced ejection fraction. And more than 50 is preserved ejection fraction. Now we have fourth group, which is called improved ejection fraction. A patient with a heart failure with reduced ejection fraction is improving his ejection fraction to 40. He doesn't come into mildly reduced ejection fraction. He comes into improved ejection fraction. So this is a classification, and today our attention is going to be heart failure with a reduced ejection fraction because of want of time. So what are the aims in the treatment of heart failure? To achieving 4 Qs. One is to increase the quantity of life of the patient, so the patient lives longer and continue to pay us. And second is to increase the quantity of money with the patient. We always think of increasing quantity of money with us. How to increase the quantity of money with the patient is to reduce hospital admissions. And third is to improve the quality of life of the patient. And fourth is now this acquired kidney. As you treat heart failure, the heart is becoming better and better. The kidney is becoming bitter and bitter. So we see a lot of cardiorenal syndromes as we treat heart failure. So these are the 4 Qs we are supposed to achieve in the management of heart failure. So it is imperative to understand some pathophysiology before we go into the medical treatment of heart failure. Heart failure is primarily due to because the heart is not able to contract or relax properly. So that results in backward failure of congestion in the lungs, congestion in the systemic veins, which we call as congestion or backward failure, or it is not able to pump forward, which is called forward failure. So the system puts in some compensating mechanisms to make sure there is no congestion and increase in cardiac output. And the compensating mechanisms of renin-angiotensin system, aldosterone system, your sympathetic system, and arginine vasopressin system. These are the good guys to start with. But as the days go on, what happens is these good guys becomes bad guys. So there is excessive increase in peripheral resistance because your renin-angiotensin is acting powerfully. Your sympathetic system is producing arrhythmias and catecholamine is necrosing the myocardium. And arginine vasopressin is going to retain water. Your aldosterone is also going to retain water and sodium. So what the poor heart has to do is it has to pump more amount of blood against increased resistance. So this is because these bad guys are, to start with, they are put in to make sure the congestion is relieved, the cardiac output is going to be improved. We met success in heart failure when we started blocking these compensating mechanisms. So to start with the medical therapy, what is very important, general measures first. Correct the correctable cause. Don't keep on treating aortic stenosis dyspnea without correcting aortic stenosis. Then of course, the important thing of a heart failure patient is to give him a weighing machine. Any weight more than 2 kilos in 3 days, he is assuming is actually increasing his fluid overload. So adjustment of diuretic at this point in time will prevent exam of heart failure. Heart failure is not like a flu. He cannot stop medicine within 10 days. He has to continue the medicines. It is not as if heart failure patient has to lie down 24 hours in his bed. When he is better, regular exercise up to his exercise capacity is advised. Smoking or alcohol to be stopped. Patient should take less than 3 grams of salt and take 1,500 milligrams of fluid per day. The vaccination is more important today. Pneumococcal vaccination every 5 years, flu vaccination or viral vaccination every year. And please look into the prescription. You should not be taking NSAIDs, steroids, glitazones, all will exacerbate heart failure. And any heart failure go into precipitating cause. The basic heart failure may be there, basic etiology of heart failure may be there, but one cause may be precipitating heart failure. If you are not treating this precipitating heart failure, the patient is going to keep on coming to you because you are not addressed what is precipitating the heart failure. A for anemia, arrhythmia and alcohol, B for beriberi, C for cardiac toxins, D for drugs I said in the last slide, and severe exercise, emotion and pulmonary embolism, fever, goiter, hypertension, hypoxia, infections, giving 3 to 5 bottles of saline. So some of the general practice, when the patient says he's tired, you will deal five bottles of saline in a patient with a heart failure. They will better the pulmonary. So always go into treatment of the precipitating causes. This is a slide I'm using for the last 20 to 25 years from OP. This tells you how our compensating mechanisms are not working, and actually they are increasing the episodes of heart failure. So now we have to block these compensating mechanisms. So how to block this mechanism? First one is to block the renin-angiotensin system. The renin-angiotensin system can be blocked by either AC inhibitor or angiotensin receptor blocker. These are the first drugs which gave us the success in heart failure in 1987 by consensus trial. They are mortality reducing drugs. So they improve the quality of life for the patient. Check creatinine and potassium before you start and keep checking them for potassium increase. Avoid them in a dehydrated patient who has got already low sodium because the first dose hypotension is very common. The most important lesson is up titrate the dose. Don't be starting with the 2.5 milligram and keep 2.5 milligram throughout his life. And if even the patient's neighbor coughs, we stop AC inhibitor. Patient need not cough. If the patient's neighbor coughs, we stop AC inhibitor. But please make sure patient is motivated to accept the cough and continue AC inhibitor. Because we can say this is going to save his life, he will accept the cough and continue AC inhibitor. Contraindications are pregnancy, bilateral renal artery stenosis, severe renal failure, and hyperkalemia. And always the debate is between AC inhibitor or ARB in heart failure. AC inhibitors are the best in heart failure. If they are not tolerated, because intolerable situations like this, we can switch off to ARB. The only ARB which is used in heart failure is valsartan. So next success mechanism was, in spite of this AC inhibitor, patients were still dying. They died because of an arrhythmia, because of sudden death. This is because of increased sympathetic activity producing the arrhythmia. The next system we have to block is sympathetic system. The sympathetic system is blocked by the beta blockers. The three beta blockers used in heart failure are bisoprolol, carvedilol, and long-acting metoprolol. None of the other beta blockers are used. A very small trial is for nebivolol, but we prefer these three drugs. Once again, the most important practical point in starting a beta blocker is you have to start the beta blocker in a stabilized patient, a dry patient. You should not be starting beta blockers when the patient has got acute pulmonary edema. And once again, uptitrate the dose. Starting beta blocker is not enough unless with the heart rate of less than 60 per minute. So you may be patient on a beta blocker, but the patient heart rate is 100, your beta blocker is not working. So make sure you attain the heart rate and don't start beta blocker whenever the BNP continue to remain more than 1000. The patient will get exaggerated heart failure. You know the contraindications for beta blockers. The next system you are going to block is aldosterone, which is going to retain sodium and water and increasing the preload. The aldosterone is blocked by two aldosterone inhibitors, mineralocorticoid antagonist, MRA they are called. They are spironolactone and eplerenone. Once again, look at the creatinine and potassium. Only when it is 2.5 and the potassium is less than 5.2, you are supposed to start. Don't combine all the three, AC inhibitor, ARB, and also aldosterone antagonist. Combine either one of them. And spironolactone, the most important side effect is gynecomastia. Eplerenone is a selective MRA. The ideal candidate you can actually guess when the patient is on full dose of AC inhibitor, still his potassium is little on the lower limit. It means the patient has got excessive aldosterone in the system. So that is the ideal candidate to add on an MRA. So once again, the specific drugs in sleep apnea. The patient has got a refractory heart failure, you have to look for sleep apnea. The best drugs will be the aldosterone agonists. The next system is, if you are not able to use AC inhibitor and ARB because of contraindication, how to reduce afterload. That is done by the combination of hydrolazine and nitrates. Whenever the AC inhibitors and ARB are not tolerated, we can switch on to hydrolazine and nitrate, which once again give you the mortality benefit. And we can also add this, in spite of AC inhibitor, ARB and ARB, the patient continue to have the symptoms and signs of heart failure, his blood pressure is good, we can also use them as a modern therapy. The next is, we have to look at the ventricle. We have to improve the performance of the ventricle. Does not give you mortality benefit. It is improving in quality of life, a symptomatic benefit. Two conditions you have to be careful is hypothyroidism and carpulmonale, because they easily precipitate the digoxin toxicity. In spite of using digoxin and beta blockers, your target heart rate of less than 70 is not achieved. Then comes ivabradine, which is a selective sinus node inhibitor. So it is a funny channel blocker. So patient on a beta blocker, heart rate is not achieved less than 70, or patient cannot be given a beta blocker and the heart rate is more than 70. Ivabradine can be used. Once again, a mortality benefit is there for ivabradine. Once again, whenever there is a beta blocker and heart rate is above 70. So it's very important to see the heart rate and the pulse rate in every visit of your heart failure patients. We keep looking at the blood pressure. We hardly look at the heart rate of the patient. The best thing is to achieve the 60 to 70 heart rate in every heart failure patient. The next thing is we have to reduce the amount of load coming into the heart. We have to excrete sodium and water, thereby reducing the preload. That is done by the diuretics. The diuretics are loop diuretics and thiazide-like diuretics. They are given for backward failure, by which I mean pulmonary venous congestion in the form of PND and orthopnea. And a large GDP. Furosemide always should be used twice daily. It should be 8 a.m. and 3 p.m. Don't give furosemide at 8 p.m. So always given twice daily. Furosemide and torsemide can be given once daily. Which can excrete sodium and water. So unlike the AC inhibitor and ARB, diuretics can be beautifully combined. You can combine a loop diuretic with the metolazone plus an aldosterone antagonist. All the three diuretics can be beautifully combined. The most important practical point is if the patient is an inpatient, if you are giving a diuretic, IV diuretic, he must lose 1 kg per day. Then only you are giving an adequate dose of diuretic in the patient. So for 27 years, we thought our job is to block the bad guys. The bad guys are the sympathetic system, the renin-angiotensin system, aldosterone system, and so on. And we have used the AGAC inhibitors, ARBs, MRAs, and also the beta blockers. But it took 27 years to realize, why don't we actually upregulate the good guys? We forgot the good guys like NAT2 peptides, which not only produce vasodilation, they also reduce fibrosis, they also produce a good cardiac remodeling. So how to upregulate is to block the inactivator of the AMPs called neprilysin. So that is sacubitril. So why don't we use sacubitril alone? The sacubitril not only increase AMP, it also increase angiotensin 2. That's why it has to be combined with an ARB like valsartan. Then came the birth of ARNI in 2014. So entire scene changed. So the ARNI, what has happened is, so now what we think is it is no longer neurohumoral inhibition. It is neurohumoral modulation. Block the bad guys, upregulate the good guys. That is the birth of ARNI. So the ARNI gave us 3 cues. It reduced the mortality, it reduced the hospital admissions and increased the quantity of money with the patient, and also it improved the symptoms of the patient. So that's what the RD did. And the important lesson is that in every patient the heart failure today, because the RNA has come out of patent, and it is available freely with less cost. So change over to ARNI from ACE inhibitor and ARB in every one of your heart failure patients, because the trial of paradigm heart failure is ARNI compared to the ACE inhibitor, and whatever the percentage I showed you is over and above and compared to the ACE inhibitor. The mortality reduction is much more when you compare to the ACE inhibitor. So please switch on the ACE inhibitor to ARB to the ARNI. One important precaution is when you switch on from ACE inhibitor to ARNI, you have to leave a 36 hours of gap. So that's a very important practical point. You can straight away switch over when you are IRB to ARNI, it's no problem. But the AC inhibitor to ARNI, it takes time. Then 2019, we gave an anti-hyperglycemic drug, SGLT2 inhibitors. And we realized it not only controlled diabetes, it had a huge benefit on the heart. By blocking sodium hydrogen ion exchange or inhibition, it improved the calcium kinetics inside the cardiac cell. It gave the better energy substrate in the form of ketone bodies, beta-hydroxybutyric acid and glucagon. It increased erythropoietin and gave more oxygen to the cardiac myocardium. It vasodilated and it introduced the interstitial fluid, and it had a hemodynamic benefit of reducing preload and afterload. And the most important benefit is there that by reducing the proximal tubular absorption of glucose and sodium, by delivering more sodium to the distal tubule, to distal glomerular apparatus, it reduced renin and also protected the kidney. So that's what that important drug is. When you use ACE inhibitor, it is a hemodynamic drug. When you use trimethylazidine or carnitine, it is a metabolic drug. Whereas SGLT inhibitor is both. It has got a powerful metabolic benefit in the form of increasing oxygen delivery, better energy substrate, better calcium kinetics inside the cardiac cell, and of course improve the glucagon. So it not only gave you cardiac benefit, it also gave you the renal benefit. And it has been shown that it works not only in diabetics, but also in non-diabetics, irrespective, today we know, irrespective of ejection fraction, it works. So once again, it satisfies 3 Qs we have already told you. What is the 4th Q? So these 2 drugs have shown, as you treat heart failure, the decline in GFR is halted or reduced. So that's what these drugs gave us the 4th Q of quiet kidney or protecting the kidney. So that's why the SGLT inhibitors are the sensations today in the treatment of heart failure, be it diabetic or non-diabetic. Too good is also a problem these days. We have too much of drugs in heart failure, drug jam in heart failure. We have ACE inhibitors, ARBs, beta blockers, diuretics, hydrogen nitrates, trimethylazidine, ARNI, the oral anticoagulants, anemia treatment, and 2 fellows are coming, Vesiquat and omecamtiv are coming. So we have confusion, what drug to start, what drug to add, what is the time frame. So that's what the problem is. Let us say one option is start like history. First is ACE inhibitor, second is a beta blocker, third is MRA, fourth is ARNI. Then of course you are a SGLT inhibitor. It will take 6 months for your drugs to come into the patient. That's why we suggest this rapid sequencing of this fantastic 4. The fantastic 4 are beta blockers, angiotensin inhibitors, MRAs, and SGLT inhibitors. So for that, we like you to look at the blood pressure, heart rate, and whether the patient is dry or wet. The patient's heart rate is good and the BP is normal or high, is dry. Start with beta blocker plus SGLT inhibitor, then add ARNI and MRA. Of course, when the heart rate is not high, it is low, but has got a high BP, is a wet patient, start with ARNI with the SGLT inhibitor and subsequently add MRA according to the potassium. Once the patient is dry, add a beta blocker. But the patient has got a good heart rate and blood pressure is dry. Start all the 3 together. Beta blockers, ARNI and SGLT2 inhibitor, and checking potassium and MRA. In this way, you can get these drugs in place in 4 weeks. So that's why the most important number in heart failure registration fraction is 4. You achieve the 4 Qs with 4 drugs in 4 weeks. So that is the essence of medical treatment in heart failure. So now the drugs can be divided into quantity giving drugs and quality giving drugs. The quantity giving drugs are the quantity, increase the quantity of life, or the ACE inhibitor, beta blocker, hydrogen nitrate, MRA, RNA, SGLT inhibitor. And of course, the quality giving drugs are RNA agent inhibitor, loop-diuretic and digoxin. In this situation, the doctor is happy because he is increasing the quantity of life for the patient. And here the patient is happy because he is able to live without dyspnea, edema and so on. And next thing is the protecting the kidney by SGLT inhibitor. Here everybody is happy, including the nephrologist. So this is the essence of the treatment. Then the new drugs which are going to come are Versiquat and Omecamtiv. Versiquat is already available here. Versiquat acts by sensitizing the soluble guanide cyclase for nitric oxide. So it will have a better utilization of nitric oxide in the body. Thereby, it is promoting all the good things. It reduces remodeling, it reduces myocardial thickening, and also remodeling and fibrosis, and also has got a vasodilatation. Today, the indication to Versiquat is a patient coming with repeated episodes of heart failure in spite of all your drugs in place. The fantastic four in place, diuretic in place, digoxin in place. In spite of that, the patient has got recurrent episodes of heart failure. Now the drug to be used is Versiquat, although it's very costly. By the time I tell you these drugs are so costly as Versiquat, the patient will not have money to buy food. Naturally, his cholesterol, diabetes, and everything will come down. So this is a slide I use as the last slide in many of my talks of heart failure for the last 20 years. And the progress we made in heart failure is telling us how many modifications I made this slide. I made 3 modifications to start with. Today, I am telling you how many modifications I made in this slide. The heart failure is nothing but a weak horse pulling a full load of wagon up the hill. The full load of wagon is the amount of invested into heart. The hill is your peripheral resistance against which the heart is working, and the weak horse is your weak myocardium. So this is the scenario of heart failure. You use diuretics, venodilators, and empagliflozin, dapagliflozin to reduce the amount of load in the wagon, reducing the preload. By making the surface plain, instead of the horse climbing the hill, make the surface plain. By the vasodilators like ACE inhibitor, ARB, RNA, hydrogen nitrates, and EMPA and DAPA, now Versiquat. And if the horse is not moving at all, whip it by positive inotropic agent. But if you keep on whipping the weak horse, it will die. That's why you briefly whip the horse whenever the horse is not moving, and don't use the positive inotropic agents continuously because that horse will die. Once the heart starts moving, don't let it run. Let it walk slowly with the beta blockers, evaporating. Make the heart take Kauery log, metoprolol, long-acting metoprolol, evaporating, so that it reduces the workload of the heart. And improve the nutrition of the heart by giving a better energy substrate. By beta-hydroxybutyric acid, by empagliflozin, dapagliflozin, and iron, and also the Omecamtiv. Omecamtiv is a myosin activator. So it gives extra strength to the horse. If none of these are working, put a pump behind the wagon. Push the pump. These pumps are CRT, ICD, and left ventricular assist devices. If nothing is working, change the horse by cardiac transplantation. So everything you are doing, but still the wheel is not there, the cart will not move. The wheel is the kidney, and protect the kidney with SGLT inhibitor. So when you look at everywhere, the SGLT inhibitor is there. So with that, you combine other drugs to optimize the treatment of heart failure with reduced infection. Thank you for your patience.
It's an excellent review of heart failure treatment. Very comprehensive, very detailed, and a lot of new concepts, like you emphasized on the Fantastic Four, in which earlier we used to say that we go up on the dosage until it is they reach the maximal tolerated dosage, but that's not the concept anymore. So we go up faster, get in the 4 drugs, even though the dose may be slightly low.
It was a very good presentation, sir. And I would just like, you have covered everything, pharmacological actions and pathophysiology, everything, and the mechanism of action, and and how to go about with the treatment. Just a few things about ACC-AHA guidelines has classified heart failure at risk, pre-heart failure, symptomatic and advanced heart failure. So when the patient doesn't have any structural or functional abnormality, it's termed as at-risk heart failure, where hypertension, diabetes, OSA, everything is there. Pre-heart failure is where we check on NT-proBNP, where diastolic function, hemodynamics of filling defects, everything. So clinical symptoms are to reduce the hospitalizations, as you rightly said, and advanced heart failure, where we have to avoid the hospitalizations. And we have to RV, whatever you were saying, that was very right. And we have to, according to the trials also, first give a trial of if the patient RV is not feasible, then we go to AC inhibitor, and ARV is the last. If again, we always have to monitor the patient for hypotension and reach the maximum dosage. As you rightly mentioned about the trials of ARNI paradigm, and a lot of from Paramount, Paragon, so many trials are there. And about the beta blockers, any three can be used: bisoprolol, metoprolol, or carvedilol. And isolazine definitely has a benefit over and above if the patient's blood pressure is maintained, and evaporating also. And SGLT2 inhibitors to finally MRIs, which I already mentioned. And I would like to mention about measuring NT-proBNP. If it's in picograms about 125, or based on the age, we can have the values, and definitely it has a prognostic value, and where the conversion of pre-heart failure to symptomatic heart failure. Thank you. Any questions?
I'd like to invite the panelists to give a token of appreciation to Dr. Ranjan.
Hey. ಬಂದಿಲ್ಲ ನನಗೆ ಝೂಮ್ ಇದೆಯಲ್ಲ ಇಬ್ರು ಹೇಳ್ಕೊಳಕ್ಕೆ ಹಂಗೆ ಹೋಗ್ಬಿಡಿ ಅಡ್ಡ
On stage, Dr. S. Venkatesh sir, Lead Consultant of Cardiology, Aster RV Hospital, Bangalore. He will be talking about interventional treatment for heart failure.
Thank you. Good afternoon, everybody. It's an honor to stand here. Kauery, Team Kauery has done a wonderful job putting together the scientific symposium. I also would like to congratulate Kauery hospitals. You know, with people like Dr. Sudayapan, Dr. Anantaraman, Dr. Ajit Pillai, Dr. Kumar, Dr. Arvind Kumar, Kauery has already made a wonderful name in the last 20 years. These are household names even in Bangalore. So coming upstream with two hospitals in the reverse direction of Kauery in Bangalore, you are established two good hospitals. So I'm sure patients in Bangalore also will benefit from the expertise of people here. Especially, I would like to congratulate Dr. Deepak, a good friend of mine, who's joined Bharatali as Kauery Hospital. So after this wonderful summary of what exactly happens in medicine, in heart failure, I would like to talk about interventional therapies. Cardiologists typically divide themselves as interventional cardiologists or the heart failure medicine specialists. Some hospital-based cardiologists also, pride themselves for being able to be good in critical care medicine, because there's a lot of medicine that goes in heart failure. But what seems to be overlapping, and it should be there, is this treatment of interventional heart failure. It's a new concept which is coming up, where interventional cardiologists will look at heart failure as one of the destinations. Here, not only interventionist has technology and skill with them, but they should also have an understanding of hemodynamics, the physiology, the pathophysiology, and the pharmacology, and also looking at the patient's life history, the progression of heart failure to put in interventions where they are required. So if you look at a continuum of a patient, you have patients with acute who require acute therapy, patient with a cardiogenic shock in anterior MI, for instance. Such a patient needs primary angioplasty, maybe hemodynamic support in terms of IAB or impeller. As heart failure progresses, while the GDMT kicks in, the guideline directed medical therapy kicks in, patients are going to continue to deteriorate, and then that is the time when we look at etiology-based therapies. There could be patients with multivascular disease, there could be patients with valvular heart disease, arrhythmias, so these have to be treated. Over a period of time, at some point of time, CRT, as Dr. Naipal said, and then later, more advanced hemodynamic support, either as a destination therapy or as a bridge to transplant will come in. So this whole thing is not just heart failure medicine, it's also critically dependent on, of course, not just the interventional cardiologist, but also a surgeon. Because after valvular interventions kicked in, the transcatheter heart valves became available, cardiologists have learned to talk to surgeons. We are now sitting together and working together as a team, and that's when the best examples will be in heart transplant. So this is a patient who had acute LVF. The panel on the left was a emergency room echo. You'll see that there is LV dysfunction, there was multivascular disease. Patient underwent multivascular stenting. Then over a period of time will be improved. So complete revascularization is also a treatment for interventional treatment for heart failure. So when we talk about GDMC, we also look at the etiology of heart failure, and coronary artery disease is one of the important things, one of the important etiologies to rule out. Valvular heart disease has traditionally been treated, but we generally talk about valves as if there are some hemodynamic structures. We look at echo gradients, we talk about severity of lesions or mitral regurgitation, but we rarely, we do talk about patient symptoms, but we have to understand that at the end of the day, valve dysfunction leads to heart failure. So when we treat heart failure, we look at the valves as well and treat them. As Dr. Naipal said, if a patient has aortic stenosis and you give medicines, unless you treat the aortic stenosis, it doesn't go away. So, few examples here. With heart failure being a burgeoning problem, and also valve disease because our population is aging, and also, like in these two examples, patients who have had bioprosthetic valves in the past, 10-15 years ago, coming back with degenerated valves. So, to treat valves with interventional therapy, could be surgery, but then also interventional cardiology, transcatheter heart valves, like this one, it's a valve in valve tabby, and that one, transcatheter mitral valve replacement. So these can also alleviate heart failure. So heart failure has to be, in etiology-based treatment in this. Pacing, of course, cardiac resynchronization pacing is great, and it is done a wonderful job. But now, recently, there has been an increased tendency to do what is called as left bundle branch pacing. So here is an example where you see the ECG after a physiological pacing. ECG shows narrow QRS. Such patients can also benefit similar to CRT. So this is one of the newer advances that has happened. So we have to look at wide QRS, left bundle branch block with LV dysfunction, and treat them with either physiological pacing, that is left bundle branch pacing, or resynchronization therapy. We see a lot of tachycardiomyopathies, VTCs, like this patient, incessant atrial tachycardias, atrial fibrillation, VTs. These can cause tachycardiomyopathies. So that could be one of the etiologies for heart failure when we treat these with either drugs or ablation many times. Because it's heart failure can increase. So these are the traditional things which a cardiologist does in the OPD. Look at the rhythm, look at the valves, look at the etiology of heart failure and treat with interventions. But then there are other things which is happening now. I sort of normally just walking in. These are experts dealing with heart failure,
dealing with devices which help advanced heart failure. Here, one of the devices which is underutilized in my opinion is intra-aortic balloon pump. In acute decompensated heart failure, not related to MI, we commonly use in a primary angioplasty if there is a cardiac shock, hypotension, we commonly use intra-aortic balloon pump. But there is also a good case for ADHF not responding to typical treatment, ventilators, inotropes, inodilators, diuretics. If you have such a thing, we can have a good afterload reduction and a modest increase in cardiac output by using IABP. It is ideal for scenarios of heart failure where there is a disproportionate increase in systemic vascular resistance, but the patient is not on frank shock. It improves cardiac output. The SVR drop is also quite good in patients with ADHF than in myocardial infarction. But only thing is, when we decide to put a patient on IABP when there is a refractory heart failure, one has to realize that what are we doing here? Is the patient a candidate for further therapy? Like, for example, will the patient receive an LVAD or will the patient receive a cardiac transplant? Because many of these patients, we put them on IABP, they may salvage immediately, but then they'll have to go on to either mechanical circulatory support of advanced nature, or they may require a heart transplant. So IABP alone may not be sufficient in some patients, but there are situations where we can use IABP to bring out patients who have got refractory heart failure. There are sessions about Impella, ECMO, and LVADs in the next few distinct talks, so I'm not going to elaborate on this. But as the intermax heart failure rate goes down, as the patient becomes worse and worse, there is a role for IABP or Impella or ECMO in patients with heart failure. These again become a realm for interventionists who have a special interest in heart failure. So therefore, to learn about not only the technique of implanting, developing the skill for implanting, one also has to understand the physiology of how these things work and in what patients these have to be used. What else is new in heart failure? So one is interatrial shunt devices. Now, some of the devices which I'm going to talk about next are not, some of them are not available in the market. Some of them are only experimental. But the point is, industry gives us technology and it is for us to test them out and see whether they are appropriately usable in some patients. Many of the trials which are conducted on these devices may not show overall benefits, but at the same time, there could be one of those patients who might benefit from a certain device. So to know what is available, to learn the skill to implant these devices and to know what the technology going behind and the physiology of the patient is very, very important. So you have intratracheal shunt devices where an elevated LA pressure can be alleviated by creating a suitable interatrial shunt. So many of these are available, some of them not here though, some of them are experimental, some of them are already in the market, but this can decompress the left atrium without causing an increased pulmonary condition and can alleviate symptoms of heart failure. Elevated LA pressure is a poor prognostic factor in patients with heart failure. We all know that. There is no definitive role for this, but then there are some patients who might benefit from interatrial shunt devices. There are many techniques of LV reshaping or surgery on LV like aneurysmic Vidal procedure, Batista procedure. We have learned about them. But then there are some interventional or hybrid procedures which can also do the same. So one can put in time and learn the skills for this. For example, I'm showing one particular system. It's called biventric system, whereby through the jugular vein going into the right ventricle, anchors can be mounted on the right side of the septum, interventricular septum, and through a minimal access surgery through the lateral thoracotomy, the anchors can be placed on the LV free wall, and together these can be tethered so that the LV size becomes smaller and the scar size can be reduced. So this kind of procedures are available. There may be an appropriate patient for whom they can be used. It's also important to know that there is a lot of innovation which is going on. Scientists are working hard. So to keep a track of what is going on and eventually learn these techniques, or to see what patients these can be applied is a very important issue for us. Remote monitoring of heart failure patients is in vogue. People monitor pulse, weight, sitting in their offices, they come to know what is going on and then accordingly treat. But then non-invasive devices are patient dependent. If the patient doesn't want to wear, for example, a wearable, or he doesn't want to, or he or she doesn't want to report weight, then we can't do anything. So implantable remote monitoring systems are available. These can be of huge help in monitoring these patients. For example, there is a system called CardioMEMS, heart failure monitoring system. PA sensor is inserted through right heart cath. This PA sensor, every night the patient can log into the desk side monitor, and the data is sent to the patient. The physician. The physician can see the readings and can decide if any intervention is required. Usually, the PA pressure changes happen much before the patient becomes symptomatic. So you get a lead time. If we see that there is a change in PA pressure data, we can predict that the patient is going to have fluid overload over a period of time, maybe a few weeks ahead, and appropriate medication change can actually prevent hospitalization. So this is one of the important things about reducing admissions is one of the important things about remote monitoring in heart failure. There are small trials which have looked at it, and they have found that you can reduce, if we use the implantable monitors for PA pressures, we can reduce the hospitalization incidence. AF and heart failure, we all know that if the patient has prevalent AF and develops heart failure, whether HFpEF or HFrEF, there is an increased mortality. Similarly, if a patient with heart failure develops new onset AF, again it's a problem. So treatment of atrial fibrillation, either restoring to sinus rhythm or rate control, is beneficial in heart failure. I think that goes without saying. We have all seen that. So there are trials which have looked at ablation as ablation AF to improve heart failure outcomes. This is an older trial. We know that maintenance of sinus rhythm reduces hospitalization and also symptoms and some mortality benefit in earlier trials. So this is a multi-central RCT, which has also shown that there is a risk reduction when compared to ablation. When compared to medical treatment. So in patients with refractory heart failure where AF is a troublesome issue, AF ablation can be helpful. And it has been shown in MRI-based studies also that such interventions can helpfully remodel the LV, improve the LV function, and also reduce fibrosis. So there is some data that AF ablation in select patients with heart failure can help. CCM is a special treatment. Here there is a pacing lead in the right, there are two pacing leads in the right ventricle where high voltage, long duration biphasic electric signals are delivered to RV septum during absolute refractory period of the heart, QRS. At that time, there is no contraction which is initiated, but there is improved intracellular calcium handling, and this seems to help the myocardial contractility. And there are some trials which have shown that there is improved quality of life and also improved LV function. So mortality benefit may or may not be there, but these are useful therapies in some of the patients. So interventional treatment is a kind of, you have to amalgamate a lot of things: technology, skill, and knowledge of the pathophysiology, and also by the side the patient's pharmacology. What is the progression of his heart failure? So there are newer, bolder approaches are on the horizon. It's not just an intervention like coronary intervention or valvular intervention. There are a lot of other things which are going in the horizon. To know this and to train in these, and for us to, some of us, to become not just interventional cardiologists or heart failure medicine specialists, but also interventionists with special interest in heart failure, seems to be a way forward given the fact that heart failure is on the rise and many structural causes are there as etiologies for heart failure. Thank you very much.
Thank you, Dr. Venkatesh. Very extensive review. There are always controversies of PCI with LV dysfunction. Some, of late also there have been various studies and how beneficial it is and other things versus optimal medical treatment.
So I made this comment at the outset that we know that there may not be trial evidence to these, but sometimes there is one specific patient in whom you actually see dramatic benefit. So I think it's not just about applying guidelines and trial results to as a blanket to all patients, but when you see a patient to know exactly what the patient is going through and to apply a certain technology to that person may make a big difference. So,
this may be coming in true because the medical therapy is on the rise and we have newer drugs. And that is why, that thing earlier they were very clear that PCI with LV dysfunction has a definitely a benefit including mortality. But now,
yeah, you never know. My patient is also on GDMT. So I can't say that it's only PCI that helped, but then one has to go by the instinct.
yes, if they're still symptomatic, we have to definitely.
It was an excellent talk by Dr. Somala Venkatesh. And it started from the lot of new interventions were told, and cardiogenic shock, antivolumine, CRT therapy in a white QRS, and transcatheter valve replacement in case of severe MR, and also aortic valve replacement. Complete revascularization was also told, as he told, rightly told, as per the case scenario, definitely after the viability. And valve and valve TAVI, there is also about AFib catheter interventions was revealed, and some newer procedures were told, interatrial shunting devices with reduced airway pressure, and also LV reshaping, aneurysmal surgeries or intervention. Also, also anchors on the right side of the IDS and LV free wall, PA sensors also. So it was an excellent talk, and it's a very good talk, and it's very sensational for me to just convey that he's my brother. Thank you.
Thank you, sir, for a concise and a very informative session. I request the panelists to please hand over a token of appreciation to our speaker. I also request the audience to please feel free to ask questions. We have 2 minutes of everything. Thanks, sir. Thank you. Next up, we have Dr. Rajesh Tia, Senior Consultant, Cardiovascular Surgery, Kauery Hospital, Electron City, Bangalore. Dr. Rajesh Tia has a wealth of experience with over 20 years in the field of cardiovascular surgery and has performed over 5,000 surgeries. He's also the first person in Asia to implant a third-generation artificial heart in a terminal heart failure patient. He'll be speaking about the current scenario of LVAD in India.
On behalf of Team Kauery, I welcome you all. Thank you for taking time out of your practice and attending this summit. As the name suggests, this is going to become an annual affair, and I'm very sure it's going to become more popular every year. Today, I'm going to talk to you about left ventricular assist devices. I'll stick my talk to the durable or the long-term LVADs. And whoever has organized these talks has correctly sequenced it. First comes the medical management, then comes the interventional treatment, and then LVADs. Many of the times when these patients come to us for LVAD implantations, they have already gone through all these things. They'll be having a lot of devices and cables and things like that. There was a time when these LVADs used to be topics we used to read in the textbooks, but it is no longer. All of us, there are a lot of us here in the audience in the country who are regularly offering and practicing this form of treatment. I'd like to take you through today through this exciting journey of this therapy, how it started in our country, where we are now, and where we are headed. The patient is being optimized medically before they hand over to me. Just to recap, what are these ventricular assist devices? As we know, they are mechanical pumps or devices that can take over the function of the ventricle and aid in its recovery or act as a bridge to transplant or can be used as a destination therapy. This is a pictorial depiction, a very common picture that we see in many of the papers and textbooks and talks, but it's very nicely depicted, so I keep using this. So you can see this is the pump. It is situated below the heart. It is connected to one of the ventricles through which it draws the blood and pumps out blood into one of the great arteries. So this is a basic configuration. If it draws blood from the left ventricle and pumps it into the aorta, it's called the LVAD. If it draws blood from the right ventricle and pumps blood into the pulmonary artery, it's called the RVAD. Most of the durable VADs are designed and used for as an LVAD. There are components of this VADs. There are the internal components, which includes the pump, the inflow cannula and outflow cannula, and the external components, which includes the controller, which is the brain of the device, and the batteries, which supply fuel. They're both connected by a drive line that passes through the anterior abdominal wall. This used to be a major factor, and it still is, before patients agree for this form of therapy. This therapy started in 2008 in our country. I implanted the first third generation durable LVAD. It was the first implantation in not only India but also the entire Asia. It was an Australian device called VentraAssist by a company called Ventracor. It was approved for both transplants, bridge to transplant and destination therapy. It was a very fantastic device actually. It was a small titanium cased device, just weighing 300 grams. It had only one rotor inside that was suspended in the blood. It had no bearings, no attachments. Because of this, it was expected to be very durable, and the incidence of hemolysis and thrombosis, that is trauma to the blood, also was very less. This is how it works. When blood enters, because of the application of magnetic field, it gets suspended and it rotates. And it draws blood to the inflow cannula and pumps it out into the outflow cannula. This configuration ensures trauma is less and the incidence of thrombosis is also less. And because there are no bearings, it is expected to last for a very long time. This is a pictorial depiction of a patient implanted with the device. You can see this is the pump, inflow cannula connected to the left ventricle, the outflow cannula connected to the aorta, coming out through the anterior abdominal wall, and connected to the controller. The controller and batteries are housed in a nice case like this, which the patient can carry. We were able to implant 4 devices in 8 months when it was introduced in our country, but unfortunately in 2009, when there was this financial meltdown all over the world, this company couldn't survive and it shut down. Even there were other companies which tried to take over this company, but it didn't happen. And there were no implants till 2012. In 2012, Thoratec company, which is owned by Abbott now, came down to the country, and they introduced 2 devices over a period of time, and both of them are still available. That is the HeartMate 2 and HeartMate 3. This is the HeartMate 2 device. It's a continuous flow, axial flow device. This is just like the fuel gun we see when we fill up our vehicles with the petrol and diesel. It draws blood from the inflow cannula, and this is the rotor, and pumps it out through the outflow cannula into the aorta. It is approved for both the bridge to transplant and destination therapy, and currently it is the most widely used, and the largest experience of has been with this device all over the world. This is HeartMate 3. This is a very small, tiny device, again by Thoratec, now owned by Abbott. And this is a centrifugal device. It's approved again for both the bridge to transplant and destination therapy. It's a very small device. It sits in the pericardial cavity very nicely under the heart. And it is done very well.
It has a very low incidence of complications, major of them being thrombosis and stroke, hemolysis, and pump malfunctions. Currently, it is the most commonly used device. This is just for completion's sake, I'm mentioning this device. It was a device called Hardware, which was taken over and marketed by Medtronic. This is again a centrifugal device, third generation device, small one, sits in the pericardial cavity and works in the same way, but it had a lot of issues. It was recalled by FDA in 2021 and is no longer available because of increased incidence of neurological events and mortality and risk of potential delayed or failed restart of the internal pump. In 2008, when I trained and came back to the country, I myself had a lot of doubts. Is this feasible in our country? The device manufacturing companies were not ready to sell the devices to us. Forget selling, they were not even ready to come down to our country. In fact, the first implant I did, that company's CEO, we had to meet in a European conference and convince him about our hospital, our country, and then forced him to come down to our country. There are a lot of concerns when we started, primary of them, and even today, it's the cost. The first device we implanted, it cost around 34 lakhs. Now HeartMate 3 is 3 times that cost, almost 1 CR. The technology at that time was very complex. The treatment was very complex, and we were doubtful whether we will be able to train the patient and their families to understand and be able to manage these devices. Another important cause for concern, even in the West, even today, was infection. Whether these devices, especially with the drive line sticking out, what will be the incidence of infection? How will we be able to control it? It's just a depiction of a infection, drive line infection. It's a very dreaded complication even today. And hospitals were not ready to invest to run these devices. Even in the West, where this therapy is very well established, even today, hospitals have to really take a decision before they run these programs. And acceptance. At that time, our own cardiologists were not willing to refer patients to us. They were just standing by and watching us implant these devices and to see what happens. And patients, see, affordability is a different issue. In our country, a lot of people can afford. It may not be for the masses, but a lot of people can afford. But they were not convinced of the therapy at that time. In fact, I had one patient who was with a technical background. He knew of these pumps, especially the second generation axial flow devices, because he was working for a company which used to design and manufacture such kind of devices. But even he was not convinced. He came to me very late, and I was not willing to do the LVAD at the time for him. But today, it is all changed. In 2012, one of the workers who was in the earlier company, he moved to Thoratec. He was very close to me, and he had experience of working in the Asia Pacific market. And I was able to convince him to bring the devices from Thoratec to the country. That's how it started in 2012. HeartMate 2, HeartMate 3 came down over a period of time. Today, there are more than 30-35 centers which have implanted and which have experience of handled these devices and offering this therapy. And there are 5 to 6 centers which are regularly doing and regularly offering these devices. Predominantly, it is still these 2 devices only that are being implanted, and around 25 implants happen per year. Around 150 implants have happened so far. There are a few other device companies which are now in the country, like there is one Eva Heart that has come down. There is Berlin Heart, which is bringing its device. It is now very well accepted by physicians and patients. The physicians refer now specifically for LVAD implantations. There is increased awareness among general public also. There was a time when these patients used to be treated strangely, especially in our airports, because they had to avoid the metal detector and things like that. But now it is not an issue. It's become a common affair in the country today. There are very good infection control measures in place. Surprisingly and very happily, we didn't see any abnormally high incidence of infections, especially the driveline infections in the country. There are a lot of steps taken to address this infection, prevent and treat them. First one is to ensure that the driveline doesn't move so that the skin heals around the driveline and creates a nice seal. For this, first the driveline is sutured to the skin so that it doesn't move, and then the skin grows around that. And secondly, a belt is provided to secure and hold the driveline in place. There are a lot of infection prevention protocols that are taught to the patients. They have to dress the exit site every single day, and they are taught how to do it on their own without the help of any other assistant. And these protocols have ensured that the incidence of these driveline infections are not abnormally high as compared to the Western experience. This is one of the belts that has been used. You can see this is the exit site. Dressing has been done, and the belt holds the cable driveline in place so that it doesn't move. If it does not move, the skin that has grown into it won't break and won't lead to infections. Indications, of course, we have bridge to transplant and bridge to destination therapy. In our country, predominantly it is destination therapy. The reason is different. It is not that the patient is not suitable for transplant. It is because of the cost involved. They're all self-funded, very expensive devices, self-funded. And so a person who has undergone this device therapy after having spent such a large amount of money, and especially when he gets used to it, and he finds out that he can do all his activity with very few limitations, then he is happy with the device. So he refuses a transplant. The reason for destination therapy indication in the West is because they are not eligible for transplant. Here it is different, but like in the West, in our country, the destination therapy indications are more. I would like to just touch upon a couple of complications which are important in this form of therapy. Of course, a lot of all the complications are important, but which I felt is significant in our country. It is the RV failure and how it is managed. In patients with heart failure, when they first present to us, they have majority of them have biventricular failure. In these patients, when we are consider them for LVAD implantation, we have to properly assess the RV. And the issue in our country is that they present very late and their RVs are very bad. So we have to have a very high threshold for accepting such patients. I have seen surgeons who have taken up these high-risk patients, not prepared properly, and then suffering in the peri-op period. There has to be pre-op optimization. This could be aggressive anti-failure treatment, including ultrafiltration and even a short period of mechanical circulatory support. We had a protocol when we were implanting those devices of putting an IABP in all the patients overnight. And then post-operatively, they have to be supported well. In the peri-op period, they might require RV support in the form of an RVAD temporarily or an ECMO. We also one has to be careful about delayed RV failure based upon the indications for which it was implanted. Cost is still a very major factor. It is not for the masses. Of course, there are quite a significant segment of our population who can definitely afford this, but it is still not for the masses. And there is significant investment required by the hospitals also. However, we are seeing now there are a lot of hospitals which are offering, corporate hospitals, government hospitals, which are offering very good heart failure services, including transplants and VADs. So now there are more hospitals willing to invest because they understand the importance of having a full-fledged heart failure program. For the patient, there is a major initial and recurring costs. Recurring costs will be replacement of batteries and other accessories. So what is the way forward? Have our own indigenous device. There have been a lot of attempts previously also. There was a project being done by DRDO where they made the design and it was ready for trials, animal implants. But unfortunately, some of those scientists resigned and went off to the private sector and it was shelved. But now there is a very promising project going on. It is under the translational research being conducted by IIT Kanpur, where the scientists have involved end users to take their feedback and device manufacturing company also. It's called Hridayantra. It is the good thing is that it is ready for animal trials. And since this time, the end users and even medical device companies are involved, and there is, of course, a lot of funding. We are very optimistic that this device will come out. And the expectation is that it will be 1/5 of the cost of the most popular, most widely used device right now. If that happens, it is not only good for our country, but we can offer a made in India device to the rest of the world as well. Thank you.
Excellent talk, Dr. Rajesh. You brought along with you 2 decades of experience in LVADs. Thank you for sharing.
Sir, in your experience, how many years of LVAD follow-up you have seen? Bridge to transplantation is fine. Otherwise,
My own patient, which I did in the first series, he had the HeartMate, the ventral assist device for 10 years. And the only reason he agreed to undergo a transplant was because the company had closed, there were no accessories available, and the driveline started to fracture. So finally, he was convinced that he has to undergo a transplant. He was so used to the device that he was refusing for a long time. That was the longest 10 years I have personally seen. He was doing very well. HeartMate 2 experience also, there are a lot of reports of the device having gone for a long time. Sometimes they have changed the device and then kept the patient on device therapy for a decade.
Otherwise, on an average, you would say 5 to 7 years?
No, these devices are fantastic. This ventral assist device, initially it was thought that it will last for around 8 to 10 years, but based on their clinical experience, it was expected to last for 12 to 14 years because the design is such that the wear and tear will be very less.
Any questions from the audience?
Why he? No. Unfortunately, we did the transplant. He had a very stormy post-op course, lot of complications. He had a neurological complication. We couldn't make out why he had the neurological complication. He had a protracted post-operative course. He recovered, was discharged home, but he came back with drug-induced renal toxicity, required dialysis. And during one such dialysis, he had a cardiac arrest and he died. Unfortunately, he was doing very well on the device for 10 years. And then he was in his 40s. He was a case of post-MI cardiomyopathy. Stent had been done, but it was not working. He presented to us in heart failure. Huh? He was a diabetic, yes.
If there are no questions.
Yes, he underwent a cadaver transplant. When he came to us, at the time, 2008, the donations were very less. So we didn't have a heart available. And we had this device, we offered to him. He was very sick. He agreed, so we went ahead and did the LVAD.
Great talk. Of course, it's interesting. There are now 2 devices being built in India that are undergoing animal trials and rumors of another 2 up north as well. So it's an interesting scenario, but because patients are being referred so late, and I would dispute the fact that our clinicians and the general public really are au fait and knowledgeable about this, because we're not seeing the timely referral. So would it not have been better to actually design a total artificial heart so you don't have to use 2 separate LVADs to be used wrongly in an RVAD configuration? Because that's where the real problem is. And I think that's where the market is going to be in the future. I mean, there are 2, 3 devices internationally, 2 available, 1 about to come out. But I would have thought that's where India needs to go. What's your opinion on that? And the other thing is, in terms of the long-term outcomes, again, we haven't reached equipoise vis-a-vis heart transplantation. It's likely to get there, but it's not quite there. So the quality of life is definitely way better after heart transplantation. So again, I stress, if only we could get this message out much more, that a timely referral means an earlier heart transplant, which gives you the best quality of life to date. But the future, we don't know. Great talk.
I agree with you to the point, Dr. Kumud. It was just a comparison to where we were in 2008, where our own, except the cardiologist who was involved in the heart failure program, no other cardiologist was ready to refer cases to us. It has changed. Of course, it has to improve, but change has been for the good. I agree with you. There have been a lot of research, a lot of devices that come out that have been used as LVADs. But unfortunately, not many people have thought of using a device with a BiVAD configuration. I agree with you, but I think it will change. And for the good, I don't know. I had a lot of experience with transplants also at that time, but I still felt whatever this is a point we can debate over dinner. I still feel these LVADs are, as a technology, as a therapy, much better than transplants.
How many cardiac transplants you have done, and what is the success rate?
This was in the first organization I worked in. Before I left that organization, I had done 4 only. But after coming out, not been able to do many transplants. But here in Kauery, we are on the verge of getting transplant license at Bangalore. Of the 4 patients we had done, 1 died in the post-op period. The 3 others are still alive, and 1 patient underwent a retransplant also.
All of them are alive?
3 are alive, 1 died in the post-op period. No, sir. It is, if you have the coverage, insurance will cover. If you have a 1 crore insurance, it will cover. Yes, yes. Cadaver transplants are also now covered. Transplants are definitely covered in the insurance. Insurance now allows even for donor expenses, even air ambulance and things like that also are allowed in insurance now. Insurance has matured. Problem is with the coverage. Like in the West, we don't have that big covers. You know, even today, most of our patients will be having 2 to 5 lakhs of coverage. That is not enough even for a routine ICU admission. Yes. Lot of the patients who are undergoing LVAD implantations in the country are of Indian origin, who come to know about this availability of the therapy and the success in the country, and they come down. Thank you.
Thank you, Dr. Rajesh.
Thank you very much.
I would like to request the panelists to give a token of appreciation to Dr. Rajesh. Next, I'd like to invite Dr. Kumud Kumar Dittal, sir, Program Director of Heart and Lung Transplantation Unit at Kauery Hospital, Bangalore. Dr. Dittal is a surgical pioneer of DCD, donation after circulatory death heart transplantation, first of which was performed in 2014 at St. Vincent's Hospital, Sydney, Australia.
Thank you very much. I'd like to thank the organizing committee, the panelists, and esteemed guests, ladies and gentlemen, to talk to you about heart transplantation, about patient selection and some surgical principles. I'm going to walk you through some background. When we refer to patient selection, it's not just the recipient, it's also the donor has to be considered. It's often neglected in these talks. I'm going to go through what may be a little bit of a dry section of the talk. We'll skip over some of the slides and then talk to you really at the end, some really basic principles about surgery. So here we go. I mean, this is what, 56 years ago now that this first heart transplant was done. And, you know, that led to almost a level of such great confidence that people wanted to do transplants everywhere. And this was a sign that was designed to go in Cape Town. And unfortunately, the results were appalling, so much so that many countries abandoned transplantation altogether for the heart. And in fact, in the UK, it was even absolutely decreed that no money should go even into the research. And largely, this was on account of the lack of adequate immunosuppression, poor preservation of the heart. And when we got good immunosuppression, when we could do distant procurement with preservation on ice with appropriate cardioplegic solutions, then of course things change dramatically to the point where now this is ISHLT registry, which captures 80% of the activity. So we're doing well over 6,000 or 7,000 heart transplants a year globally, with phenomenal results, whereby even up to 5 years later, over 80, even more than 80% of the patients are doing well with hardly any hospitalization, particularly for rejection and infection. And majority of them are leading normal lives and returning to work and contributing to society, paying their taxes and so on. So the results are good. It remains a gold standard. And I know Rajesh and I will have our debates, but so far, if you talk to any cardiac surgeon or transplant surgeon, they would prefer heart transplants of an LVAD, but he's the first exception I know. But I hope that one day artificial pumps will be the mainstay of therapy, because deceased cadaveric transplants are very depressing. It involves somebody having to die, and that's not the best way to start, but it's all we have at the moment. So results of survival, great. Look at 10 years, over 60%. And if you survive the first year, your survival goes up to beyond 75%. It's the most crucial year where rejection and infection can take hold. But we're supplying probably less than a tenth of the transplants that we need to be doing. And in India, the figures are even worse. So how do we actually choose? And in choosing, we need to know a little bit about heart failure, but I'm not going to go over this except to say when you should seek to refer patients to a heart failure, or rather an advanced heart failure and transplant center. That's a mnemonic. I need help. I'm not going to read this out to you. Much of you will know this. But it really is a composite of clinical symptoms, signs, and laboratory values that determine when you should be referred. And don't forget, the later you leave that referral, the more complicated is going to be the time course of that patient. It's going to completely exceed the package costs of the transplantation. They will exceed the 3-week supposed stay in hospital. And of course, mortality will also go up. And hence in India, we still don't have a registry. So this is heart failure. The only thing I want to mention here is we talk about NYHA class and stage A to D. And it's better often in terms of your referral not to be so focused on the NYHA. Patients can be treated and come in and out of NYHA classes, but you cannot come in and out of a heart failure staging. You can only progress and get worse. If you end up in stage B, you can never return to A. C, you can never return. And hence, once you're at stage C, you need to start thinking about really referral. So these are the obvious cardio indications, but there are lots. So cardiomyopathy of various sorts, idiopathic, whether it be familial, ischemic, valvular heart disease, congenital heart disease, but congenital heart disease that has not got Eisenmengers and fixed pulmonary hypertension, infiltrative disease and amyloidosis and sarcoidosis, and any condition really that limits your survival and risk of death being about 50% over the next 2 years. There are others. I mean, don't forget, greater than 10% of heart failure patients are already in stage D, and a good proportion of them already need transplantation. It remains a class 1 indication. Now, I'll be referring to in the donor selection a lot about class and level of evidence, class 1 and a level. And so just remember, the class is really you must, you should, maybe, and don't in terms of 1, 2, 3. And the level of ABC is really about a meta-analysis of randomized studies, and good control studies. Okay. So contraindication transplantation, foremost is really that fixed hypertension in the lungs. Often heart failure clinicians making the mistake when they're not experienced of just bringing the patient in for a right heart catheter study, finding a high TPG, and then denying the patient a transplant. In fact, what you need to do is to make them euvolemic first. You need to treat the heart failure first. And then if it's still high, admit them, give them some milrinone, dobutamine, whatever for several days, and then repeat the right heart study, because you would otherwise find that they are still eligible. Active sepsis, particularly in relation to mechanical surgery support. Again, all those I'm not going to read through, but there are lots of impediments. And don't forget psychology, and hence your psychological review as part of the workup is crucial. So any multidisciplinary member who looks at that and reviews the patient has the potential to veto the transplant going ahead. It is crucial. The last thing you want is a non-compliant patient, whether it becomes whether it's related to medication intake or attendance for their surveillance clinics and biopsies. So what should you do pre-transplant? So again, be vigilant of their status, monitor deterioration, try and seek advice. It's always better to involve the advanced heart failure transplant team early on. So there's a tripod of patient, heart failure, the referring physician, heart failure, transplant physician, so that they can reinforce each other. Trust then develops, which I'll touch on a bit later on as well. And there's a workup, of course, it's about a 2 to 3, sometimes 4 day of admission, top head to toe examination, largely to rule out occult disease, particularly cancer. So age over 40, you'd need a colonoscopy, upper OGD, and so on. It's very much tailored to the patient, but a huge number of tests. Some of you might be doing CPETs, which is the exercise test. It's not mandatory, but it helps delineate those on the borderline in terms of their physical capacity to know what their oxygen consumption is. Okay, the greatest surgical advance would be that we practice evidence-based medication management, which we, heart failure management, which we saw in the earlier on, that only 18% are practicing this, and a timely referral for a transplant assessment. And the benefit of that referral is the continued patient education go on, patient is engaged, there's a building up of trust because the patient is not only being told they need a transplant, but they also have to spend such a lot of money and be having to be disciplined about the post-transplant management of their lifestyle. So the risks are better evaluated and they become far more compliant with instructions post-transplant. Do not wait until you get renal impairment, pulmonary hypertension, or frailty to the point where you end up with very high risk for the patient that may have to be removed from the wait list. Okay, donor selection. Now, I'm really praising a paper that came out last year from ICHLT, from Hannah Copeland and colleagues. And this gives you the first paragraph is important. Her father was Jay Copeland, who was in a different scenario in those, but only optimal donors should be accepted. And now we've had to widen the marginality of the donors because of the shortage. So the headings will tell you what section's about. Again, class and levels are delineated there. So donor hemodynamics, we know what we're aiming for. So we know a large inotrope use, particularly vasopressor use in respect of noradrenaline, is detrimental to outcomes in the early phase post-transplantation. We know from work, I was also involved in, but way back in Papworth, and studies from Indian colleague Venkateshwar, who's in Manchester, and others in the US, that if you have the time, then for the cardiothoracic transplant team to get there early, sometimes 3, 4, 5 hours early, and take over the donor in the ICU to manage them, even with the Swan Ganz, particularly in the borderline marginal donors, increases that conversion and makes the organs better, even for the livers and the kidneys. And that is a well-established practice, certainly common in the UK, and it really increases the number of donors that can be converted. So those are the parameters we seek, the mean arterial pressure, CVP, wedge, cardiac output, and so on. And of course, a metabolism of the donor in respect of hyper or hyponatremia, hyperglycemia not being a contraindication. Donor death mechanisms, you can take donors with carbon dioxide poisoning, even explosive brain death, or unexplained sudden death. But you have to be careful in the context. And if you see the bottom one, the 2B, we're losing a little bit of evidence. So age, again, it says the ideal donor is under the age of 45. I've used donors up to 65. And it's all a matter of matching the donor to the recipient and the urgency of the recipient, how likely they're likely to die on your wait list. And in which case you will take whatever option you have. But if you're very careful about it, if they've got an angiogram or good assessment on an ex situ perfusion platform, it can be used, and you can. There is no upper age limit actually for a donor in terms of evidence. Donor size, the typical match that gives you poor outcome is a female to a male. But again, if you practice a recipient protective strategy and you match it well, then your donor will have a good outcome. So you can do that, but you have to be careful. There's some limitations. And it's best nowadays to use the predicted heart mass ratios between donor and recipient. HLA incompatibility, again, the incompatible ABO transplantation is restricted to pediatric group where there's some phenomenal results, but not so much in the adult. Ischemic time, we're told that it should be less than 4 hours, but actually in hearts under the age of 35, as was the practice in Australia, we'd be routinely using ischemic times of over 6 hours with excellent results with the hearts bouncing off the bypass machine. So it's all a matter of individualized donor recipient matching. So if you have a marginal organ and then don't go for the long trip, don't go for the marginal heart. So things have to be right. You don't want to compound the risk factors, otherwise you'll end up with a disaster. And as I said before, stick to a recipient protective strategy always. Donor comorbidities, LVH, that used to be very fraught. You can certainly do that with extra cardioplegia, preservation solution that is, and you get good results. If you again do not compound risk factors and make sure that the LVH is restricted to younger donors and shorter ischemic times. Donor coronary artery disease, donors can have single or multiple vessels. It all depends on whether it's amenable for percutaneous or surgical repair. So you can do heart transplant with coronary artery bypass graft surgery. Again, because there's going to likelihood of accelerated vasculopathy compounding the ongoing coronary artery disease, you're going to be matching that only when you have the urgency to get a recipient transplanted, particularly in scenarios where LVADs are so expensive. I'm going to skip a lot of this stuff. So diabetes is not really a risk factor, but except to note that they do have an increased risk of coronary artery disease, and you may want to be advised in some of these patients to do a coronary angiogram where it's possible. Cardiac arrest and CPR time, again, are not contraindications from the donor. And as long as at the time of retrieval, the LV has improved in function, then you can go ahead and use it. And that's been practiced very routinely. Drug use, tobacco, again, unless they're doing more than 20-pack-year history of tobacco, then as long as the LV is fine on assessment, you can use it. Alcohol, the same thing. And illicit drugs, again, can be utilized as long as the function on echo and there's no structural abnormality. And now I'm going to miss a lot of these infections, but just to suffice to say that whether it be bacterial, fungal, or even bloodborne viral infections, again, you can, in desperate times, utilize these. I guess the most common one right now is the expansion of heart transplantation with hepatitis C positive donors, because we know we can treat that post-transplant with success. It's become not so much of an issue. And in South Africa, with matching HIV to donors to HIV recipients with very good outcomes. Again, TB in itself per se is not a contraindication, but you'd have to, again, do the appropriate matching and make sure that there is a post-operative adequate therapy for it. So these are really the patients who are at risk of having post-operative infection. Again, you can quickly scan through those on the right-hand side with very good evidence at class 1 level B. So these are, again, there's some emerging viral pathogens like COVID and so on that, again, can be utilized after the donor has, when you know about the history of when it was diagnosed and when the retrieval time is, and ideally they should be free from it at the time of transplantation. And same goes with parasites. Now, CNS infections, you'll see you do not want to utilize meningitis, whether it's viral, fungal, or amoebic. Bacterial ones you can sometimes if it's isolated to the CNS. Malignancy, again, it used to be a big no-no. But again, if it's a non-melanoma skin cancer with the risk of low recurrence or low-grade primary brain tumors, those donors are completely fine for heart transplantation. So it depends very much on what it is. If it's a adenocarcinoma of breast and colon, you want to be 5 years free in remission. But prostate, now they're bringing that down to about 2 to 3 years. But raised suspicion of metastatic disease is very important, and you may want to do a thorough assessment of abdomen and the chest before doing the retrieval, and maybe you do biopsies on table at the retrieval center if need be. So biomarkers, apart from troponin, which we know can be released in the context of brain death, should not be utilized to negate the retrieval. It depends very much, putting in context, as to the risk factors for coronary artery disease separately that the donor may have. And pro-BNP, we've heard again, whether it be NT-BNP or pro-BNP, they do, they're useful, but they're not independent factors, again, to withhold a recipient from having that heart. It depends on, again, on the clinical context as to whether the donor has got some structural heart disease. Imaging is very important. Echo is mandatory pretty much. And if there's been an initial low EF, then do not please refuse the organ. Continue to look after it with serial echoes, particularly in the young. These will get better and become useful and retrievable and converted to a transplant. The stress strain 3D echoes are rarely done, but they do add extra elements when you've got poor visualization, or you want that contrast enhancement for better idea of myocardial function and viability. The MRI is rather limited in terms of availability in most of where you might be taking donor hearts from, and therefore it has only a 2B level C evidence. Okay, so extended criteria donors are really hard to match recipients with donor low EF and so on. And those, we are now commonly utilizing these. Patients with valvular abnormalities that you can repair on the table before implant, and those patients, donors on VV ECMO can be utilized, and VA ECMO very rarely. Domino transplants, we rarely do that. We used to do that from cystic fibrosis who were getting a heart-lung block, and the recipient's heart would go to another person. I'm going to skip over this given the time and talk about some surgical principles. How do we put it in? Well, there's a classic biatrial technique where you're joining the atria, the aorta, and the pulmonary artery. And then there is the more common bicaval technique now where you're doing the SVC and IVC anastomosis separately. Then there's a French technique, which is, again, limits then the enlargement of the left atrium, and hopefully it reduces even more the frequency of dysrhythmias. But B is the typical one that's utilized. Remember, do not explant the heart for a bicaval anastomosis before you are absolutely certain about the length of the IVC, SVC that's going to arrive. Leave it as a biatrial explant, and then you can always then cut out the right atrium to allow a bicaval. Heterotopic transplants we rarely do now. So last few things, appropriate team. Have you got everybody that you need there? The timing and logistics are absolutely crucial. You do not want to be there on bypass for too long, have you explanted the heart and the donor heart hasn't arrived, nor do you want the donor heart to be arriving way before you have explanted the heart, particularly in a reduced stenotomy or in a VAD explant, where you could be there for a long time trying to get hemostasis. Induction and right heart catheter, repeat the right heart catheter. Make sure that you're happy to go ahead. Plan for the unexpected, plan for the worst. So you have an idea of what you're going to do if things go wrong in terms of cannulation strategies as well. And again, respect geometry when you implant, because that could end up in a disaster. Recognize when you're going to reperfuse. So a DCD heart, marginal heart, you want to reperfuse early, left atrial anastomosis, aorta, and then reperfuse. A normal heart, you do all the anastomoses and you do it with calm and time. How long? I do 15 minutes for every hour and then reduce my flow by half a liter every 5 minutes. And then weaning off pump is important because sometimes you can't and you may need a balloon pump or sometimes even ECMO, and you should be ready. But hemostasis is the goal, pre-implant, hemostasis post-implant, because the risk of you really want to reduce the risk of renal damage, which is going to be compounded by immunosuppressive therapy. And so blood products do that. So just very short on the principles, because most of it applies to every surgical procedure you do. Thank you very much.
Thank you, Dr. Detan. It was an excellent presentation. definitely DCD has allowed for prolonged ischemic times now compared to the earlier thing of less than 4 hours. So increasing awareness is more important. And like Sir said in the previous talk, adequate referral, timely referrals, and those are the things which need to be emphasized on.
It was a very good presentation, sir. What about the contraindications in your experience? Diabetes with complications or obesity, which has twice mortality more than the other candidates?
Could you say that again? What is
the recipient being a diabetes with complications or the recipient being an obese person more than
yes, so
the
actually the outcomes are worse with people who have a BMI, particularly for lungs or even for hearts, who are cachectic and have a BMI below 17 than those that are around even above 30. In the West, they're typically, some of them are 30. So you will transplant them, but beyond 35, it becomes a no-no, really, because they will not mobilize as well. If I stuck anybody, even the fittest person here in bed for a week in ICU, when they get up, they would lose their coordination balance and probably fall on the floor. So it becomes really difficult to get them through, not least the risk of infection and sternal stability.
Thank you.
We'll take questions from the audience.
Kumar, that's fantastic summary. One question and a comment. First thing, obviously, heart transplant. Now you have worked in 3 different continents and you have seen the outcomes, Australia, UK, as well as India. Your perception on the outcomes that's going to be in India. And the second thing is the donation. We have seen the best donation is in Spain because the opt-in, opt-out comes in. And do you think that should be the case in India so that we have more donation and more outcomes and more transplants?
So first question, outcomes. Outcomes in India that I've seen is certainly not as good as elsewhere. I think that is not because of, well, 2 reasons. One is patients are arriving too late. So there's sicker patients being transplanted. Some of them wouldn't even make it to the Western wait lists, and they're on India. So we're transplanting a far worse substrate. The second is that we haven't had that time to build trust with the patient for them to be compliant post-transplant. I don't consider a hospital discharge as a success. The patient must live at least until their natural history, had you not operated on them, right? So everybody that I've seen says, oh, discharge, success. That is not success. They must live a lot longer. The other issue about opting out or opting in, Spain does not necessarily have, despite the opt-out, does not have the best conversion to an actual transplant, right? But you're right, where the countries have gone to this opt-out business, then they have got much more donors. I think it would be phenomenal. If we had that in India, it would be just amazing. You'd be doing thousands of transplants that are required. But you don't have the expertise, you don't have the teams. And I think it'd be premature because you would end up with so many donors that then do not get utilized, and people would start getting very upset, and you'd have a negative effect on organ donation. People would actually write in to say, I don't want to be on this list. So I think it's a good idea. Maybe it should be in a state that is more mature, where people are more literate, that can be trialed as a pilot before it goes elsewhere. But I think it needs time. You see, until we have you guys referring on time, I can't believe that the opt-out, just having donors, is going to help us.
Yeah, my comment is exactly that. Obviously, we have got hospitals, now we have got network of hospitals like Kauery, we have got network of hospitals, and most of the cardiologists can treat heart failure. That's not a problem at all. But where it comes to important is, as is shown in your slide, when it comes to that stage C and D, before it goes to D, it's important for this patient to come to the advanced heart failure clinic and meet with the heart failure consultant who is directly involved with the transplant. It's not that they're coming for transplant, it's meeting this heart failure consultant for a general consultation and then making sure that they are in a stage where we continue medical treatment, they are in a stage where we categorize into device, or they are in a stage where we say you need transplant. The second thing is it creates a good rapport with the heart transplant team, the heart failure, the surgeon and the other team, so that the patient's confidence increases. That's what I have seen. If the patient comes early, if they meet with us, if we assess them early, if we do transplant, the outcome is exceptionally good. If you send the patient after that, when their kidney and liver is gone, even with the transplants, we will not win.
You're so right. That is so misunderstood, this tripod that I mentioned earlier.
Yeah.
Because when they come to us, we can reinforce that good work is already being done by their referring physician. That makes the patient even closer to their referring physician, saying, oh, he's doing well. And we say, listen, we're just here in the background until you need a transplant. And that allows them to have trust in us, because eventually we're all three are going to be required to look after that patient. So I absolutely agree with that. Yeah, thank you.
So just a second, sir. Sir, excuse me. So just a second. Thank you so much. So we request our panelists to give a token of appreciation to our speaker.
Now, I'd
Thank you, sir. Thank you, madam. We will now have a formal inauguration to today's program. I call upon Dr. Rajani M, our chief guest for today's function, Joint Director, Medical, Health and Family Welfare Services, onto the dais, along with Dr. Chandra Kumar, our founder and executive chairman, Dr. Vijay Bhaskaran, sir, Executive Director, Hosur and Bangalore, Dr. T. Senthil Kumar, Executive Director and Head of Cardiac Sciences, Trichy, and Dr. M. Chenniyappan, Consultant Senior Cardiologist, onto the dais, please. Please, sir.
Deepam Jyoti Parabrahma, Deepam Jyoti Parayane, Deepeno Harate Papam, Sandhya Deepam Namostute. To have an auspicious start to the event, I request the dignitaries to light the lamp.
ज्योतिषां प्रभुरव्ययः ब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः आरोग्यं देहि पुत्रांश्च पतिं स्वच्छामि मे सदा रवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् रवेरस्तं समारभ्य यावत् महत् सूर्योदयो भवेत् यस्य तिष्ठे गृहे दीपः तस्य नास्ति दरिद्रता शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते शुभं कुरु त्वं कल्याणम् आरोग्यं
Thank you, everyone. Now I request Dr. T. Senthil Kumar, Executive Director, Head of Cardiac Sciences and Chief Cardiac Surgeon, Kauery Heart City, Trichy, to give the welcome address.
Respected Deputy Director of Medical Services, Rajni, Dr. Wing Commander, Dr. S.S. Iyengar, Executive Chairman, Dr. Chandrakumar, Executive Director, Dr. Vijay Bhaskar, distinguished speakers, invited guests, consultants and doctors of Kauery, honored delegates, members of the press, my dear Kauery family members, ladies and gentlemen, good evening to you all. Technological advancements lead to progress, and progress creates excellence. Education and research forms an integral part of it. In our quest to create comprehensive centers of excellence in the field of cardiology, Kauery has been in the forefront. Today is a defining moment in the history of Kauery as we embark on creating an academic platform which, down the years to come, shall set a benchmark as an academic forum for discussions and deliberations for newer developments and best practices in the field of cardiology. To inaugurate this first annual summit here in Bengaluru, we have with us Dr. Rajni. She has always been very passionate about development in the field of medicine, particularly in pediatrics, in breastfeeding, and also in PGPD&T being enacted as a law. Madam, on behalf of the management and staff, and on my personal behalf, and on behalf of everyone who have gathered here, I extend a very warm welcome to you. We also have with us Dr. Wing Commander S.S. Iyengar, a very senior cardiologist, highly renowned in the academic circles, an avid researcher, a teacher, and an excellent speaker, to deliver the keynote address. I am honored to welcome you, sir, today for today's program. Next, I would like to welcome our beloved chairman, Dr. Chandrakumar. The last 2.5 decades, if Kauery as a group has grown exponentially to a 12-hospital spread across 2 states corporate setup, it is because of his dynamism, vision, and hard work. I extend a very welcome to you, sir. Running a successful organization and expanding into newer territories requires clarity of thought, vision, forward thinking, an eye for perfection, and willingness to embrace the future. We have amidst us a very young executive director, Dr. Vijay Bhaskar. He single-handedly has nurtured and grown Kauery in Bengaluru and in Hosur. A very warm welcome to you, Vijay. We also have with us a galaxy of illustrious senior cardiologists like Dr. Chenepan, Dr. Ajit, Dr. Arvind Kumar, Dr. Anandram, Dr. Kumud, Dr. Raghuram, and so many else who are all gathered here for today's function. I would like to extend a very warm welcome to you all, and also to the innumerable distinguished guests and delegates who have gathered here today to participate in our function. We are honored to have you here. I welcome you all. Next, the press, without your support, we wouldn't be here where we are now. A hearty welcome to you all. Last but not the least, my dear Kauery family, you are our strength, our spirit. I extend a very warm welcome to one and all of you. Thank you, ladies and gentlemen. Have a wonderful evening.
Thank you, sir. We have with us Dr. S. Chandrakumar, founder and executive chairman of Kauery Group of Hospitals. Kauery Hospital was founded as a humble 30-bedded facility 25 years ago in Trichy, which now, through the dynamic leadership of Chandrakumar sir, has transformed into one of the premier healthcare brands in South India. It has around 2,500 plus beds and it continues to grow further. I request Dr. Chandrakumar sir to address the gathering.
Thank you. Good evening, everyone. Madam Dr. Rajni, Joint Director, Health Services. Dr. T. Sendil Kumar, Executive Director. Dr. Vijay Bhaskaran, Director, Bangalore Region. And Dr. Chenniyappan, and all my friends and cardiologists, fellow colleagues. Once again, a warm welcome to all of you. As the MC talked about, we are running the 25th year. And we started in the 99, 2000, just mere 30 beds, just to want to have a nursing home. Me being an anesthesiologist, we thought we should just focus affordable trauma and critical care, that being our specialty. And we had a very wonderful team. We had all my roommates, Dr. Singatu and Dr. Manivannan. I think we grew step by step. We moved to 100, then we moved to 200. And today, with all the support, we have really gone to 2,500 beds. And it looks as if we just started a few years back, and 25 years have gone by. And I, at this point of time, I would like to humbly acknowledge whatever we are today, the credit goes to all the clinicians. It is their untiring commitment and dedication had brought us to this moment. I humbly thank all of you at this time. Our single-minded focus from the day one has been the patient centricity. It's about the clinical outcome, it's about the patient safety. I think that has been the single parameter. And we also wanted to make a difference how we can make even the high-end procedures more affordable, be it the planning the hospital, or be it on optimizing the capital items or on the operation efficiency. That's where those benefits we want to pass it on to the patients. When Dr. Chenniyappan was talking, he mentioned about the quantity of money reminds the patient. I mean, really, if you look at the high-end procedures, it's quite prohibitively expensive. I think we are committed to see that how we can make it far more affordable and predictable. And can you just play that video, 25 years? Thank you. Thank you very much. Now, on the 25th year, we thought, and instead of adding beds and treating number of patients, we thought we should start focusing on actively on the academic programs. We used to do from the beginning CMEs and local region. We thought we should start focusing from now onwards 6 or 7 key departments at the state level conferences, national level conference. That is the first of its kind. And we wanted to take pre-launch of the Marthahalli unit. I think we'll be starting the second hospital in Marthahalli quite soon. And I would like to thank and acknowledge the organizing team, Dr. Vivek, Dr. Ganesh, Dr. Deepak, and all the medical admin, Dr. Mahendra and Dr. Nagesh, for really putting a wonderful show in a very short span of time. We decided somewhere mid-December. They really done a wonderful job. I was also happy to note that Venkatesh, when he was talking from Aster, he could recollect all the cardiologists from Trichy, Dr. Chenniyappan, Dr. Arvind Kumar, and Dr. Ajit and Anantaraman. I was pleasantly surprised. One interesting fact is we started 99, 2000. Till 2004, we never had a cardiologist. We had only visiting cardiologists. It's so difficult for us to get that. We opened the first portable cath lab in 2004, headed by Dr. Chenniyappan, and a group of friends and cardiologists. They put a cath lab unit, portable cath lab unit. And we had 2 cardiologists at that point of time. In 2012-13, we opened an exclusive cardiology hospital, 100 beds. Today, we have 15 cardiac catheterization laboratory with hybrid cath labs, around 60 full-time cardiologists. And we have a DNB, cardiology, cardiac surgery, cardiac anesthesia. And currently, the number of procedures we do per month, we do around 1,500 cardiac procedures. Angiogram, angioplasty devices per month, we do that. And also we do around 200 cardiac surgeries per month, putting across the units. I think clearly it talks about the ability and the contribution by the cardiologists, not the number of cath labs, but we could do this over a period of time, step by step. We didn't do it overnight. I mean, we could really at this point of time also, even in Bangalore when we started small, 100 beds, today we have got around 600 beds. Dr. Vivek and Dr. Ganesh really supported, even when we are small. I think I would like to always, I will continue to remember fondly the contribution of the clinician. The biggest difference what we have, I was talking to Ganesh and Vivek yesterday, the biggest difference for us, we being doctors, the contribution of the clinicians, the amount of struggle they undergo, the amount of stress in the time of difficult times, the patient's outcome, we fully understand that. And we are always with them. Just one point I want to quote. The last 25 years, we have around 150 clinicians in Trichy. Only 4 clinicians have left. 2 have retired, and one person, his wife is a gynecologist. He went with his wife to support that. And one person went to start a small nursing home. That is the commitment of our management with all the clinicians. I think we will continue to do so. And also, I would like to say that we have now 12 hospitals. We are also working on another 12 hospitals. In the next 3 years, we want to have 25 hospitals, and we'll be around 5,000 beds. We're planning for a IPO in the next 3 years. I take all your blessings with you, and thank you very much. Thank you.
Thank you very much, sir. In the last 2 years, every program that I have been a part of personally through Kauery, Chandrakumar sir never leaves an opportunity to thank the clinicians. It in itself is a driving force for all of us. Thank you very much, sir. On this August occasion, in the presence of many dignitaries and highly decorated clinicians, we take immense pride in having with us Dr. M. Chenniyappan, and we would like to take this chance and opportunity to honor you, sir. Dr. Chenniyappan is a senior consultant cardiologist in Ramakrishna Medical Center, Trichy, honorary professor of Indian Medical Association. He is also the director of medical education in Apollo Specialty Hospital, Trichy, distinguished clinical teacher, resource person, and advisory board member of Journal of Association of Physicians of India. He's had multiple papers in his name internationally. He's been awarded the best performing doctor by Government of Tamil Nadu, Chennai in 2018, the best doctor award in 2011, 2013 by Indian Medical Association and Tamil Nadu Medical Council. He's also received many special appreciations, the one notably by Association of Physicians of India in APICON 2014. He's also a Master Teacher Award holder in 2016 from APICON. Now I request the dignitaries on the dais to confer the highly decorated Dr. M. Chenniyappan sir with a Lifetime Achievement Award. Please, sir. Thank you, sir. Thank you, everyone.
I would like to speak a couple of minutes about Dr. Chennappan. I come from a rural village. My village population is around 5,000. I studied in Tamil medium. Okay. When I came to Trichy after my post-graduation, I lived as a tenant in Dr. Chennappan's house. Okay, for 10 years, till I started the hospital, maybe after a few years. And from that time, he has been my guide and a mentor. And Dr. Sendil and Chennappan are brother-in-laws. So a private practicing clinician, okay, in a tier 2 city, normally spends very less time in the academic activities. As far as I remember, over the last 2 decades, every week on Saturday and Sunday, he used to travel all over India, all over the world, whether it is ECG or echocardiogram. And you name any medical college, you name any academic forums, Dr. Chennappan will be there. And one of the best speakers, and he makes it far more interactive. I think that is very rare in today's practice, because we are very, very busy with all our private practice, seeing our patient, moving to one hospital, other hospital. I think it requires a true dedication, commitment to just impart the knowledge, what one may have. I mean, you could have also seen the presentation, the quality of the presentation. I think he lives the cardiology, and all the general practitioners, physicians in that region treat him like a God. Yes, whatever he says, he'll be there. And he's true to his patients, and also that is a very, very rare quality. So it's our honor to honor Dr. Chennappan. Thank you very much.
Respected dignitaries, is a surprise. I didn't expect that. So this is a cardiology, no? It comes when you're not expecting it. But good things are also coming in cardiology when you're not expecting it. So thank you, Dr. Chandrakumar. It's so nice of you to actually do this. Actually, I didn't expect it. And also, I'm very embarrassed to receive that, because as you know, the best prize for a teacher is when a student excels him. That's what we aim at teaching all of them. So I have not reached that point yet, but I'm going for a point in which a student of mine will excel me. Thank you for your patience.
Thank you very much, sir. We have with us today our chief guest, Dr. Rajani Ma'am, Joint Director Medical, Directorate of Health and Family Welfare Services, Arogya Saudha, Bangalore. Dr. Rajani M pursued her MBBS from the prestigious Mysore Medical College and DCH from Bangalore Medical College, where she was a meritorious student. She joined government service in 1991 as Primary Health Center Medical Officer, after which she has worked in various posts from Medical Officer to First Lady District Surgeon of Tumkur District Hospital and First Lady DHO of Bangalore Urban. She went on to become Deputy Director in Child Health, PCPNDT, and currently is the Joint Director and SOTO Member Secretary. She was instrumental in implementing PCPNDT and KPME Acts with special interest in fighting against selective sex selection. She is also a writer on importance of breastfeeding and increasing breastfeeding statistics, and a poet who has published more than 200 poems on digital media. With over 33 years of government service and being a decorated administrator, Dr. Rajani is a popular pediatrician in Tumkur. We are pleased to have such a personality as our chief guest, ma'am. Now, I'd like to request Dr. Chandrakumar, sir, to felicitate Dr. Rajani, ma'am. I request Dr. Rajani ma'am to address the gathering.
Good evening, everybody. It gives me very immense pleasure for inviting me here. I especially thank the Kauery Group of Hospitals administrators, Mr. Chief Patron Dr. S. Chandrakumar, and Patron Dr. S. Vijay Bhaskaran, Executive Director of Kauery Hospital and Organizing Chairman. And it gives me, I am so humbled to be here with the august doctors who treat the heart ailments, whether with their knife or other medications. I am an administrator here and basically a pediatrician. I am into administration as a DHO of Bangalore Urban, where I was instrumental in implementing KPME Act and PCPNDT Act. Now, I feel, not only now, since beginning of my medical career, I feel the hands who hold pen is always submissive to the hands who hold either scalpel or stethoscope. Me as an administrator, I just hold a pen. I always want to be and to remain a humble administrator to the august audience here. When I gave licenses, registration under KPME Act, I felt not as humble as now, because as a member secretary of SOTO, I am very happy to declare Karnataka is second highest in organ transplant and the deceased organ donation all over India. Second highest. We have done 178 deceased organ donation last year. Since the SOTO and organ transplant inception came into vogue very much technically, from 2017, more than 978 organs are transplanted all over Karnataka. And to our August, Dr. Kadal is the Transtand Chennai, we received second, the best emerging SOTO all over India. And I hope we will be number one in 2024 in deceased organ donation, because the immense popularity and the social message given by Kauery Hospital, even in this quorum, and which is going to happen tomorrow also by even all the film actors in the Film Critics Award, which is supported by Kauery Hospital, including our Dr. Rajkumar, Puneet Rajkumar, and Ashwini Puneet Rajkumar was ambassador in instrumenting the Indian Organ Donation Day, which was celebrated under recently under the guidance of our Honorable Minister, Mr. Dinesh Gundurao. And tomorrow, more than 30 to 40 film actors are going to give the message to the Society of Deceased Organ Donation. So our administration is always happy to associate with the people who do always good work, and especially Kauery Group of Hospitals, with not even single rupee exchequer to the government. Today, by just the videos which are promoted by Kauery Hospital, I am able to reach all over Karnataka. It is measured by the number of calls. Already I am getting to the Jiva Sarthakate landline. Since 3 days of the video, which is done by our popular film actor Shivraj Kumar, the family legacy which holds in giving eyes and giving good messages to the society, within 3 days of the video, I have received more than 200 calls to Jiva Sarthakate landline. So deceased organ donation is going to take a different paradigmatic shift in Karnataka. And as an administrator, I always feel, and I always look at a brain death committee, which I sign, and the doctors who change from hospitals to hospitals, whatever be the cause, I always see the same doctors, same humanity, same dexterity, and the same technicality with you, whether the pen, whether it's science for the Kauery Hospital, or it signs for the other hospital. It is immaterial to me as long as you people serve the society. And I happen to give their licenses, your committees are signed in no matter of time so that you can serve the people of who are in needy in Karnataka. So this is my aim in giving the registration to by SOTO member secretary. There are 17 heart transplant centers in Karnataka. And you know, the most awaited organ is kidney. And I came to know Kauery is one of the pioneers in doing the maximum number of kidney transplant in Bangalore. And around 182 people have registered just for heart in Jiva Sartakate. So even when we go to that state authorization committee as a member, when I see people, live donation is happening, most of the donors are females. And even in organ pledging in Karnataka, females are the highest who have registered for organ pledging. And nobody even imagine Ballari is the highest in organ pledging. And you people, we people think that the most forward cities will be highest in organ pledging. When I did a radio program in Akashvani, the number of calls I got is highest from North Karnataka. I don't know whether it is due to the micronutrient deficiency or the uncontrolled hypertension, or the waiting for the kidney, which has made them call, and opening dialysis centers. And we have to somewhere protect the deceased organ donors as well by road safety and decreasing the number of brain deaths. It is a double-edged sword. When the number of deceased organ donation, more than 80% are due to brain death. So as an administrator and as an officer in government of Karnataka, I have to think in all lines, but I from my heart, I humbly thank you for the Kauery Hospital to be part of this August gathering. And as an administrator in the department, I always give supportive hand to all the hospitals who do transplants. And then I became member secretary of SOTO. And when I received the award of second highest in Transtan Regional Roto in Chennai, I happened to meet a girl around 30 years who has been transplanted twice heart, twice. So when I checked my BP with Dr. Nagamallesh, I was very apprehensive. I became hypertensive after I became a joint director. But when I saw a girl with twice heart transplanted and standing with her father, I want to make heart transplant in the true sense. It should occur in government of Karnataka, under the shelter of government of Karnataka, with transparency and with such a dexterity of preserving the organs, and the success rate should be high. So I thank Kauery Hospital to give me this opportunity to see, visualize, and see the humbleness of cardiologists. I am pleasured, and with my heart, I thank the Kauery Group of Hospital to make me part of this August gathering. I thank from my wholeheartedness. Thank you so much.
Thank you, madam, for sharing your real life success stories, which is really inspiring to all of us. Thanks again. Now I request Dr. S. Vijay Bhaskaran, sir, Executive Director, Hosur and Bangalore Kauery Group of Hospitals, to deliver the vote of thanks. Please.
Good evening, all. So I am highly indebted to Dr. Rajni, JD Health Services, and SOTO Member Secretary for two things. One is her kindness to grace the occasion, and second one is when we approached her for the government of Karnataka support for tomorrow's program, in second she accepted, and also she introduced to the minister for taking the bites. For both occasions, amidst your busy schedule, you have kind enough to grace, and also for tomorrow's program also you are going to be there, and thank you in advance. Thank you very much. Then this program was consolidized, pressurized, and all whatever our chairman Dr. Chandra Kumar. So I want to thank him for this wonderful program going to be annual. Then our ED from Heart City, Trichy, who is the person defined all those things and all. I want to thank him. And Dr. Chennappan, I was his neighbor for more than 5-6 years. Thank you for giving the opportunity to honor you. Thank you very much. And also the program, the success lies with all the speakers, faculties, and the organizing team, and all the cardiologists from different parts of the state and neighboring state, and all the corporate doctors and all the wonderful team. And whatever the colors you are saying, the credit goes to the digital and marketing team and the hotel management, press and media, and all the people who gathered here. Thank you one and all. Thank you very much. Thank you.
Thank you, everyone. We have one session left from heart failure topic. Next up, I request Dr. Nagamalesh UM sir, who is a Director of Heart Failure, Transplant and MCS program in Aster Hospital. Dr. Nagamalesh sir has over 2 decades of experience in cardiology, which is interventional and transplant both. He's done over 50 plus cardiac transplants with internationally acceptable standards and more than 30,000 plus cardiac catheterization. It's a pleasure to have you with us, sir. Over to you.
First, I would like to,
So I'd like to invite our panelists, Dr. Lalita and Dr. T. Senthil Kumar sir on stage for this session.
So good evening, everybody. First, I would like to thank Kauery Hospital for inviting me to address all of you. So just now, Dr. Kumar said, discharging after transplant is not success. So what is required is continuing care of this patient. If you don't do proper follow-up and continue your care, whatever the interest you have before transplant, these patients won't make it for a long time. So we have meticulous follow-up of this patient. We have nearly done 70 transplants, and our 5 years survival is more than 85%. So that shows we have a meticulous way of following up, calling them, and available for them when they need after the transplant. So survival after heart transplant has improved considerably, especially after the invent of many immunosuppressive drugs. So now half of the patients now live more than 9 years, and 25% of the patient live more than 17 years. So once you say they live long, means they're exposing to long-term immunosuppression, they're exposing to infection, and also because of these medication, they can have diabetes, hypertension, dyslipidemia, osteoporosis, malignancies. So it is our responsibility to keep them alive and find out as early as possible and prevent major complications. So when we monitor, why we have to monitor? So monitoring has got 2 aspects. One is immediate post-operative monitoring and a long-term monitoring. So your responsibility starts once patient is wheeled out of the OT. The post-operative hemodynamic instability can be present. It is due to multiple causes like a graft reperfusion injury because of the CPB, that is cardiopulmonary bypass. They have elevated pulmonary vascular resistance because of the inflammatory reaction. All this can have, and also these transplanted organs are catecholamine depleted organs. So this also can contribute to the hemodynamic instability. So there are many studies which is published saying that when RV failure risk is 75% with a 15% mortality when pulmonary vascular index is more than 6. And it is less than 20% when PVRI is normal. So we have a lot of things like nitric oxide, sildenafil, we can give that, but we have to be very careful selecting these patients so that you have a less complications. So it is mandatory to monitor all these patients with a PA catheter, and we had to do regular TE because transthoracic echo is not visible among these patients. We can monitor the mixed venous oxygen and lactate level to see the cardiac output, and to keep the blood sugar under control because we are giving immunosuppression, so you can have infection chances. So continuous inotrope infusion is important, and we have to do it first, basically first to 2 to 3 days, and by 5 days most of them we wean off. So even though pressure is normal, we try to keep some amount of inotrope because these organ is catecholamine depleted organs. So we have to keep smallest dose of inotrope for 2 to 3 days. So another problem is rhythm disturbances. These are the parasympathetic denervated organ. So the bradyarrhythmias is common. So sometimes you can have a 60% of the patient basically when you do biatrial anastomosis, they can have bradyarrhythmia. And also you can have supraventricular tachycardia. So SVT and ventricular tachycardia also possible. So there can be chronotropic incompetence. Sometimes if heart rate is low, more than 3 weeks, then you need to have a permanent pacemaker. So if you see atrial fibrillation, especially after 2 weeks of transplant, then we have to think of rejection. It may not be there, but you have to do early biopsy and see whether the patient is in rejection. And especially when you have VT, they sustained VT, so immediately you have to do angiogram and endomyocardial biopsy, because we don't know, like a donor heart might have some coronary artery disease can contribute to the ischemia and arrhythmia. So amiodarone is safe, but you should be very judicious in using, because so when you reduce heart rate, sometimes the less than 90 of heart rate have a high risk of sudden cardiac death. So we keep heart rate little higher, like 100 to 110. That is a normal in transplant. If you see any, you may see all this, what we have done, 150, 200 transplants in Bangalore. All this patient might come for some other reason to you. But if you see the 100 and 110 heart rate, don't try to reduce. Let it be like that. It is purposely kept little higher level. So the most common complication after transplant is primary graft failure. Primary graft failure is defined as early post-transplant cardiac failure without identifiable immunological or anatomical lesion. It can be only left ventricle, can be only right ventricle, or both biventricular. It has been shown that 20 to 30% of the patient can have this in first 30 days, and those who have more than 20% death rate. So when the treatment is more symptomatic, directed against increasing contractility and improving the hemodynamic status. So when we see this, we start them on inotrope, but we don't hesitate to put them on ECMO. So we are very low threshold or starting them on ECMO. So we don't try to give a multiple inotrope and see whether patient can improve. So the most important thing in the post-transplant period is the strict aseptic precautions, especially in the subcontinent compared to West. So reverse isolation is very important. So we do antibiotic prophylaxis. Each centers have a different antibiotic prophylaxis. This is our center prophylaxis. And we give them anti-protozoal prophylaxis and antiviral prophylaxis for nearly 100 days post-transplant. We start usually 10 days after transplant and continue for the 100 days. And also the antifungal oral paint, so that they won't get oral and esophageal candidosis. So the principles of immunosuppression post-transplant is to reduce the immune reaction or rejection of this patient. the immune reactivity and tendency towards graft rejections are highest in the first 3 to 6 months. And we need to give the good amount of immunosuppression during this period. Use of low dose of multiple immunosuppression is important rather than giving a very high dose of 1 or 2 immunosuppression that can have a lot of side effects like infection, malignancy. So usually we do an induction with the basilaximab by ATG and give methylprednisolone as induction, mycophenolate, and maintenance we start them on tacrolimus, mycophenolate, and prednisolone. So we have a lot of other drugs, cyclosporin, we have azathioprine, we have sirolimus, we have everolimus. There are a lot of drugs. It is beyond the scope of this talk to explain each one why we select these drugs in particular patient. So most common problem is rejection of this. So if you put these organs in risk, the highest risk for rejection is kidneys. The next is heart, and last is liver. So heart is not so bad in the rejection is concerned, but we should be very careful selecting the donor and the recipient. So acute cellular rejection is a T cell mediated, usually occurs after first post-operative week. But if it is mild, most of them are asymptomatic. Even moderate, they are asymptomatic. Once they are symptomatic, they have high, very high level of rejection. We can do endomyocardial biopsy to see the rejection. This is the grading, mild, moderate, and severe grading. We call it as 1R, 2R, 3R. So usually 1R, we don't treat that. Mild rejection, usually it subsides itself. Only 2R, 3R, we treat them with a corticosteroid, that is methylprednisolone, we give ATG. Another complication is AMR, that is antibody-mediated rejection. So these are the follow-up what we do regularly in the post-transplant clinic. So it's humoral rejection result from antibody-mediated response to mismatched HLA present within the donor myocardium and vascular endothelium. So number of mismatches may influence the speed and degree of rejection. So pathologically, it is considered when you do a patient has come with a rejection, with a LV dysfunction post-transplant, when you do endomyocardial biopsy, it is normal. Then we consider it is AMR, we do a C3, C4D, and we see is there any rejection in that. We can see the histopathology also to see is there any interstitial hemorrhage, capillary fragmentation, mixed inflammatory infiltrate in the endothelium to see if there is a rejection. These are the grading of AMR. So when the AMR is there, initially they thought there is no AMR in heart, but in AMR in heart, it is more dangerous condition. They have very bad prognosis. We treat them as plasmapheresis 1 to 2 exchanges. We give IVIG, we give rituximab, just a standard therapy, but still it's very difficult to treat. The last complication is cardiac allograft vasculopathy. It is a allograft vasculopathy is a major factor. It is limiting the survival of these patients. Usually, by 5 years, most of the complication of immunosuppression infection will become very, very less. But after 5 years, the chances of getting graft vasculopathy, that is the one limiting the chances of patient survival. So CAV is an accelerated form of coronary artery disease that is characterized by concentric fibrous intimal hyperplasia along the length of the coronary arteries. Both immunological or non-immunological has been proposed for this theory. Immunological, maybe some rejection or low-grade rejection, which yields with the fibrosis of the vessel that can cause graft vasculopathy, or it can be due to hyperlipidemia, insulin resistance, obesity, uncontrolled diabetes, all other things which is responsible coronary artery disease can also precipitate the CAV. So we can do intravascular ultrasound to confirm that. We have a patient now, we have done transplant 20 days back. So it's a 24 years old male who came with, after 6 years of transplant, he developed graft vasculopathy. I did 3 times angioplasty. Every 3 months he used to come back with the restenosis. Usually they don't do well with angioplasty. They'll be very aggressive restenosis. And 20 days back, we done a transplant, is doing well. In a few days, he'll be discharged. So thank you very much. If any questions, I can answer.
That was an excellent, complete talk on postoperative management and long-term follow-up of these patients. Like he has said, I think the most important factor is the quality of life of these patients. Transplant doesn't end the day we discharge him, but how we follow up and how they are taken through to live as a normal human being in society. And in my little experience as a cardiac surgeon, the longest surviving post-transplant patient I've seen was 27 years. He passed away recently.
Yes.
This was one of the first patients who was operated in Apollo hospitals where I worked with Dr. Girinath. So that patient, actually, he was a flower vendor in the hospital. So he was picked up as the first patient and the entire medications were given to him by the hospital. And he was also given a job in the hospital. So he was completely taken care of. So why I am telling this is, if the patients have a good compliance of medication and simple things and prop up, immediately they get treated, they can have a near normal lifespan. So I think there is a message which I would like to add to whatever is added. That was an excellent talk, sir.
Thank you.
One small question, sir. You were telling that multiple angioplasties were done for the patient, and it's also said that if the patient has the predisposition for atherosclerosis, what is your comment on this? Is it the patient's predisposition or the graft reaction?
Yeah, so we don't know exactly what was the trigger, but patient was doing well till 2021. I've done angiogram, it was normal. So only thing is during COVID period, he had one severe COVID, followed by, I think he stopped doing diet and controlling his sugars. He's just 24 years, he developed diabetes after transplant because of the steroid and tacrolimus. So probably some of the factors, the atherosclerotic risk factors also contributed to this graft vasculopathy in this patient.
Sir, any experience with congenital heart disease transplantation?
So we have done congenital heart disease transplant. If it is complex congenital and those who come with cyanotic congenital heart disease or failed Fontan, they have poor prognosis post-transplant, especially failed Fontan. Very difficult to do transplant among this patient. They have a severe bleeding post-transplant and very, very difficult to control. So comparatively, but once they recover, once that discharge happens, they are equivalent to other people. But during transplant, so what you say, that 90% success, only 10% risk of transplant, there'll be little more than that when you do congenital heart disease.
Should both heart and lung be considered in such patients?
So those who have pulmonary artery hypertension, Eisenmangers, they'll be done not just Eisenmangers with RV dysfunction, because Eisenmangers will do very well. If you do transplant, they're early actually. So Eisenmangers patients should go on medical management. Once they develop RV dysfunction, RV failure, then you should consider for the heart and lung transplant.
Thank you very much. There are no further questions. I think I would like to.
One more. Good evening, sir. I just, as a primary physician, what are the roles we should follow? Suppose we are in a periphery, when you get a call.
Sir, loudly, sir. Loudly.
Good evening, sir. In the periphery, when you get a call of these patients, as a primary physician, are there any guidelines or this one we should follow?
Yeah.
Till we reach the
So
patient.
that is, when you do more and more transplant, they may come to you for the for fever and other things. You can land up in our clinic. But a good transplant centers usually have very good network with the transplant coordinator. They'll be in touch with you. Once they come to you, I send patient. After calling you, I'll send the patient. Our patient asks them to go there and call me. So usually you should talk to the people who are transplant unit before you start any drugs. For example, if you give NSAID for people who are taking tacrolimus, very high chance of developing renal failure. So they should be very careful giving them. And patient who is running fever, you should not give medicine and send them home. They will land up in sepsis and die. So better if you see some patient coming with a fever or any other thing, please call up the transplant cardiologist and talk to them. And if it's simple, they'll ask you to treat. Otherwise, they'll ask him to come and get admitted for the further evaluation. Even small fever, we'll take it very seriously.
That's fantastic, Dr. Amalesh. I think you summarized the follow-up things. Now, a question and a comment. The question is, we used to do 16 biopsies. That is within SHA protocol. We were doing 4 and then 12, 16 biopsies within 1 year. And doing 16 biopsies in India, it's not possible, it's expensive on all different issues. So since coming back, obviously I've stuck to 3 biopsies in the 1 year, and after that I have a different protocol which I tell. What is your practice? Because this is a completely different setup and following up.
Yeah. So basically we have to do, as per the protocol, we have to do biopsy every week, first month, and every month, first year. There'll become too many biopsies. Even now, West thinking, is it too much? Because of the protocol, they are doing it. I do 1 biopsy in the first week. If there is no rejection, I will do after 3 months. So, and every 3 months I do biopsy. So more, I think we do 4 biopsies in a year. And after that, every annual biopsies. So if person, suppose we have done a retransplant, I done first biopsy last week, and it was a 2-hour rejection. I gave 3 doses of steroid. I did a second biopsy after 1 week for this patient. So I had to customize basically because he was in rejection. I done a second biopsy. Second biopsy showed again 2+. So now I started ATG for him. I'll do next week 1 more biopsy. So this patient will go every week biopsy because it is more high risk and chances of developing 3R is very high. So you should customize rather than blindly doing or not doing. Some people say not doing, that is also I don't agree. Blindly doing toll also I don't agree because it will become very expensive for patients. So when you do transplant, you see that you save patient money. Otherwise, he'll be in soup because he'll come with fever, he will not have money to treat and he will die. So you should see that you have to save money for patients so that he will live long.
Yeah, absolutely. I think around 3 to 4 in the first year is more than enough in India.
More than enough. Yes, 4 biopsies is the protocol I follow.
Yeah.
They're doing well. Actually, we are almost nearing 70 transplant. I don't have any issue in that. Actually.
Now, the other important comment I want to make, especially for the general physicians and referring consultants, is these transplant patients, the very first symptom of rejection is simple nausea and vomiting. If a transplant patient gets nausea, vomiting, and as already Nagmalesh said, some little bit of low dose, sort of low grade pyrexia.
They can have just general weakness.
Yeah.
So when you see the general weakness or nausea, vomiting can be sepsis. Patient, no fever, nothing, is fine, he has come to your clinic with a mild nausea. So in next 3 days, he can have full-blown sepsis and die. So we have to take it a little more seriously than other patients.
Absolutely, you send them immediately because the way we save it is, as soon as we catch them early, 3 high-dose steroids, 3 pulse steroids, 1 gram per day, you save the patient. If you lose that window, after that, if you start whatever you do, you don't save the patient. So it's very important. Thank you.
So thank you. I think we are running behind time. So I think we'd like to wind up the session for now. Thank you very much.
Thank you.
I'd like to request the panelists to give a token of appreciation to Dr. Nagamalesh. Now we'll have a keynote address by Dr. Wing Commander S.S. Iyengar Sir, Senior Consultant Cardiology at Manipal Hospitals. Sir is an ex-serviceman of Indian Air Force and a renowned cardiac electrophysiologist and interventional cardiologist with extensive expertise of 54 years. He has led many path-breaking clinical trials and research products, including CREAT registry. Please, sir.
Good evening, ladies and gentlemen. First correction, I'm not an electrophysiologist.
And coming to my topic, I'm going to talk on hypercholesterolemia, familial hypercholesterolemia. Now, a few points before I start my actual talk. I'd like to convey my congratulations and greetings to the Kauery family for their quality service of 25 years, and I'm sure they'll continue the same for years to come. I thank Dr. Deepak for giving me this opportunity to be here, and I feel privileged and honored to be delivering this talk. It also gave me a great opportunity of meeting my friend, Dr. Chennappan, a great clinician and a master teacher. I never used to miss his talks whenever it was there in any conference. And I was also happy to meet some of my friends who were in the uniform years ago, some of my defense colleagues. And lastly, those who have missed it, England scored 316 for 6. And they have got a lead of 126 runs from India. Now you heard the sequence of talks, as Dr. Rajesh rightly mentioned, it started in the right sequence, but I'm going to make a complete U-turn and start with prevention, primary prevention, how to prevent people from going to hospitals, cath labs, and operation theaters. And I tried to look at the subjects, and I chose a topic, the path which is less traveled, because this is that many people are still sort of unaware of these problems with familial hypercholesterolemia. Now, all of us know that dyslipidemia is a major modifiable risk factor, easily detectable, easily treatable, safely treatable, and effectively treatable. And amongst the lipids, LDL cholesterol is the culprit, and it is not a biomarker. It is the cause of disease, and it should be the target, and it is the target for our treatment at present. And I'm going to concentrate on this second part, which I mentioned there. Prolonged exposure to LDL cholesterol increases cardiovascular risk. High LDL cholesterol throughout life is worse than having LDL cholesterol for a limited period of time. For example, patients with familial hypercholesterolemia have lifetime elevated LDL cholesterol. They're exposed to cholesterol right from birth or even right in utero, and therefore have exceedingly high cardiovascular risk compared to general population. Familial hypercholesterolemia is a genetic disorder characterized by elevated blood levels of atherogenic lipids. It results in premature atherosclerotic cardiovascular disease in the form of early myocardial infarction, stroke, peripheral vascular disease, and calcific aortic valve stenosis. It carries high morbidity and mortality. If you look at the life cycle or the trajectory of these patients as compared to a patient who doesn't have familial hypercholesterolemia, your patient who has a homozygous FH, he reaches the threshold for coronary heart disease by the age of 12 to 12 and a half years. A patient who has heterozygous familial hypercholesterolemia, which is a lesser evil of the two, he reaches the threshold for coronary heart disease by the time he reaches 35 years. So the objective is to detect it early, start aggressive treatment so that you can reduce the steepness of the slope or try to flatten the curve. And is also, of course, influenced by various other risk factors. You should take care of them so that it helps in reducing the slope of this slope. So Lipid Association of India came out with this slogan, familial hypercholesterolemia, it is time to get familiar, because it remains underdiagnosed and undertreated despite being a life-threatening condition. Now, before you become familiar with the familial hypercholesterolemia, let me show a familiar face, which I'm sure all of you are familiar. This is a painting of course, Mona Lisa, truly inspiring for many artists and those who are fond of art. And Leonardo da Vinci took 4 years to paint her picture. She was born in Florence in 1479, and unfortunately, she died at the age of 37. And some of the clinicians took a close look at her picture, and what they found was she has xanthelasma, and she had a tendon xanthoma. So it's probably she had familial hypercholesterolemia, and she died prematurely because of that, and probably the first case of familial hypercholesterolemia. Now let us look at the prevalence of familial hypercholesterolemia. Now all of us familiar right from our undergraduate days that we know what is Duchenne muscular hypertrophy, we know cystic fibrosis, we know polycystic kidney disease, sickle cell disease. But if you look at the frequency per 1,000 births of common genetic disorders, it is less than 1. Whereas if you look at the familial hypercholesterolemia, it is 5 per 1,000 births of common genetic disorders. Globally, 1 baby is born with FH every minute. This is a recent study which they looked at homozygous familial hypercholesterolemia. And if you look at India mentioned here, we have about 5,000 cases of homozygous familial hypercholesterolemia. That is, if you take the frequency as 1 in 250,000 to 1 in 360,000, that is for homozygous FH. But if you look at overall FH or including heterozygous FH, you have to multiply this by 1,000. So you have about 50 lakhs of patients suffering from familial hypercholesterolemia. There's another way of looking at worldwide prevalence of familial hypercholesterolemia, where they did a meta-analysis of 11 million subjects. So overall prevalence of familial hypercholesterolemia was 1 in 313. But when they looked at the patient population who had ischemic heart disease, it jumped 10-folds. 1 in 31 had familial hypercholesterolemia. When they looked at further patients who had premature ischemic heart disease, it was 20-fold higher. So 1 in 15 had familial hypercholesterolemia. Also, if you look at the patients who have LDL cholesterol more than 190 milligram per deciliter, the prevalence of FH will be 1 in 14. So the lesson learned to be learned here is, please try to screen for your patients in the general population. In ischemic heart disease, again, try to look for FH, and particularly in premature heart disease, look for familial hypercholesterolemia. And those who have high LDL cholesterol, again, try to look for the diagnosis of familial hypercholesterolemia. There's also something called founder effect, where certain populations experience FH at a higher frequency due to the presence of so-called founder effect. This is due to migration, geographical and cultural isolation, and loss of genetic variability. And this is seen in the French Canadians, Ashkenazi Jews, and Lebanese, Finns, and South African Afrikaners. So this one study just they looked recently where they found prevalence of FH is 1 in 300 in the general population. If you go to the founder population area, it's going to be 1 in 80. And of course, you go to Iceland, is 1 in 800. Indian data, this is a study from center in the north, where they looked at 635 patients who presented with premature coronary artery disease. They found that nearly 15% of them have familial hypercholesterolemia. Lipid Ocean of India collected these homozygous FH patients. We have about 53 cases collected over the last 2 years. 13 of them based on the genetic studies also were done in those. 16 of them are on PCSK9 inhibitors. 3 have undergone CABG, PCR, ABR. 1 has dilated cardiomyopathy. 4 are on lipoprotein apheresis. Now, what is genetics of familial hypercholesterolemia? So it's basically due to mutations in the LDL receptors ApoB, PCSK9, and LDL receptor adaptive protein, or some maybe identified genes. What is important for maintain LDL cholesterol in the circulation? You require LDL receptors which remove the LDL cholesterol from the circulation. You require ApoB to get this into the liver cells, and you require LDL RAP1, which mediates the internalization of LDL cholesterol. If any of them are dysfunctional, if LDL receptors are deficient, if ApoB receptors are dysfunctional, so is this, then LDL cholesterol will go up. The other mutation we look at is the PCSK9 enzyme. PCSK9 basically destroys LDL receptors. So if PCSK9 is gain of function, will increase LDL cholesterol. So these are the mutations which we usually study genetically. And this shows the frequency of FH cases in genetics. About most of them are due to the LDL receptor mutation, and rest of them are due to the other mutations, or it may remain unidentified in many cases. As I mentioned, I've been talking about homozygous FH and heterozygous FH. Homozygous FH is more severe form. They have very high LDL cholesterol, and the heart attack occurs very early childhood. And here it is much less LDL cholesterol compared to this, but heart attacks around the age of 35 years. How do you diagnose familial hypercholesterolemia? It is not difficult. It is very easy if you stick to standard clinical practice of taking history, including family history, meticulous physical examination, and do a lipid panel. So you can arrive at the diagnosis of familial hypercholesterolemia. If you have any doubts, or if you are more scientifically oriented, you could apply one of these criteria, which are available freely. Simon-Broom criteria, Dutch lipid clinic criteria, MedPed criteria, which is followed in US. And there's also criteria for diagnosing homozygous FH. Now, lipid recommend Simon-Broom criteria as being a simpler one, where the Dutch lipid clinic network here is usually followed most of the places in the world. Now, clinical examination, as I mentioned, of the taking proper history, these are the xanthelasma, these are the corneal arcus, these are the Achilles tendon xanthomas, and these are tendon xanthomas. The same tendon xanthomas you can see shown here. This is called out interdigital xanthoma. These are supposed to be pathognomonic of homozygous FH. These are the Simon-Broom criteria and Dutch clinic lipid network criteria, which have been shown here. You can usually apply these to the patients when you suspect FH. And Dutch clinic criteria, it also caters for those patients who are already on statins. So you could utilize this for this one. Now, once you diagnose familial hypercholesterolemia, don't stop there. Try to do the cascade screening of the first degree and second degree relatives. And this cascade screening could be only clinical, lipid, and need not be genetic. Now, what is the current treatment for familial hypercholesterolemia? Of course, the important thing is the lifestyle intervention continues to be an integral part of the management of familial hypercholesterolemia. You must correct the other ASCVD risk factors, starting with smoking, hypertension, diabetes, etc. And we have a number of drugs available to lower the cholesterol, LDL cholesterol. Statins, ezetimibe, bempedoic acid has been made available recently. Lometabide is not available in our country. PCSK9, we have evolocumab with us, and inclisiran has been again made available recently. Evinacumab is another drug which is not available with us. The non-pharmacological measures are lipoprotein apheresis and liver transplant. We have been talking about kidney transplant and heart transplant. We heard there is a place for liver transplant in certain selected cases, though this has not been well established so far as in the guidelines. To just mention about the few drugs and their effects on these patients, this is a study where they looked at 2,000 patients who had FH, who had no coronary heart disease at baseline. They were given statin. Those who received statin, they survived longer
than those who didn't receive statin. This is a study with evolocumab, PCSK9 inhibitor, where they looked at 300 patients of severe hypercholesterolemia, followed up for 4.1 year. You can see in the homozygous FH patients, the LDL cholesterol came down by nearly 50%, and in heterozygous patients, it came down by nearly 60%. And nearly 26% of them could stop their lipoprotein apheresis. This is a small study which was undertaken in our country, which our hospital was one of the centers, where 30 patients were studied in this open label phase 4 study. 13 were under the age of 18 years, and mean LDL cholesterol was 473 milligram per deciliter. If you look at this, this of course represents all the 30 patients here. In more than 50%, probably you didn't have any reduction in LDL cholesterol. In fact, it was increasing. In only about 50% of patients, you received some significant beneficial effects of reduction in LDL cholesterol. This is a study with inclisiran. Again, it brings down LDL cholesterol in these patients of heterozygous familial hypercholesterolemia nearly by 59%. Evinacumab is a drug which is a monoclonal antibody against NGPDL3, which this drug, as I mentioned, it is not available. This is the characteristic feature of this drug, or important effect of this drug, is the drugs I mentioned already earlier, statins, ezetimibe, PCSK9 inhibitors, inclisiran, they will not act on those patients who do not have LDL receptors. Those drugs are effective in only those patients who have LDL receptors. So patients who do not have LDL receptor, the drugs that have to be used are either lomitapide or evinacumab, or the non-pharmacological measures like lipoprotein apheresis. So this study, of course, with evinacumab showed that in the homozygous patient, it brings it down very effectively. So talking about treatment algorithm for homozygous FH, lifestyle intervention, correction of other risk factors, then diagnose and initiate of high intensity statin monotherapy. That is standard of care. You have to hit hard and hit early so that we get effective outcome. Then if it's not reaching the target, you have to have a target for LDL cholesterol. We talk about it in one of our subsequent slides. Ezetimibe is added to this. If there is you not reach the target with this medicine, then you could add bempedoic acid before you go on to PCSK9 inhibitors. Then next step is PCSK9 inhibitors. Lomitapide and evinacumab are not available with us, and some patients will have to go for lipoprotein apheresis. Now you heard of good cholesterol, that is the HDL cholesterol. LDL cholesterol is supposed to be bad cholesterol, and the ugly one is triglyceride. But we have one more deadly cholesterol, that is lipoprotein little a. Now, what is lipoprotein little a? Is nothing but LDL looking like moiety, but it gets attached to ApoA through a disulfide bridge, and it has plenty of oxidized phospholipids. So this is pro-inflammatory because of the oxidized phospholipids. It is pro-atherogenic because it has got a LDL-like structure, and it is also pro-thrombotic. So it is 3 in 1: pro-inflammatory, pro-atherogenic, and pro-thrombotic. So it could have devastating effects if it is elevated in the circulation. So why should we worry about it? Because if LP(a) is more than 90 percentile, it increases the risk by 2 to 3-fold of myocardial infarction, stroke, calcific aortic stenosis, peripheral artery disease, heart failure, and very high risk of mortality. Now, it has been generally agreed that those who have LP(a) between 30 and 50 milligram, they were at an intermediate risk of developing these problems. And those who have more than 50 milligram, they were high risk of developing atherosclerotic cardiovascular problems. This is one small study which was conducted in our hospital where we looked at the subjects who came for executive health checkups. And we found that nearly 20% of them had Lp(a) more than 50 milligram per deciliter. So lipoprotein little a is not to be belittled, but unfortunately we do not have any drugs recommended by the guidelines. But there are some drugs in the pipeline. We have pelacarsen, olpasiran, SLN 360, and even one new oral drug is coming out. And all of them reduce Lp(a) by about 80%. We are waiting for the outcome data so that it could be used clinically. But important thing is those, when you find some of your patients or subjects have high LP, what should you do since there is no treatment? What is important is you should look at the others, you should treat his risk factors very aggressively. And if you treat it aggressively, you could reduce his risk of atherosclerotic varices by nearly 2/3. So look at, these are the so-called 7 health metrics prioritized by AHA: smoking, overweight, diabetes, hypertension, cholesterol, physical inactivity, and unhealthy diet. But interestingly, and most of us would welcome, they have added another one, adequate sleep, which most of us welcome most of the time. And so we should ensure all these things in our patients who have LPA, you could reduce his atherosclerotic cardiovascular disease. So the question asked, why should I measure LPA when I don't have any drug which is recommended by any guidelines? The reasons are, it is a causal risk factor for atherosclerotic cardiovascular, as mentioned. It is a frequent risk factor found nearly in 20% of the general population. It is helpful for risk estimation. So if you're stuck with your risk estimation, this comes handy where you could use it as a risk enhancer so that you could use your lipid lowering strategies. So measuring lipoprotein little a, do it asking for without ifs and buts. So as I mentioned, there are drugs which are in the pipeline, and lipoprotein apheresis is quite safe and effective in these patients. Now, these are just, we have about 11 cases where 3 of them have already died. One was 45 years old, one is 13-year-old boy, the other one was 12-year-old boy. All of them had elevated lipoprotein little a. They did not show any response to statin, ezetimibe, and PCSK9 inhibitors, and 4 of them are on lipoprotein apheresis. This is our first patient of FH. He was 23 years when he had CABG. He had redo CABG at 36 years, PCI at 40 years. He developed severe calcific aortic stenosis. He died at the age of 40 years while waiting for TAVI. And his LDL cholesterol while being on statin and ezetimibe was 304 milligram. So this is, you can see the extent of calcification in aortic valve, in coronary arteries, and across whole. And this is another lady, 33 years old lady, who had already undergone CABG. And she also a case of rheumatoid arthritis and hypothyroidism. She became pregnant, and she at any cost wanted to continue her pregnancy. And we had no other option but offer her lipoprotein apheresis. She underwent 7 sessions of lipoprotein apheresis and delivered a baby safely. And these are, at present, we have 3 patients who are on apheresis. They've undergone about 29 sessions of lipoprotein apheresis. If you see here, the LDL cholesterol comes down very effectively, near about from 550 to somewhere about 250, nearly 60 to 70% reduction in LDL cholesterol after each session. And LP(a) also comes down, you've seen here, from nearly 125 to somewhere about 60. So it reduces Lp(a) also by 60 to 70%. As I mentioned, liver transplantation also has a role in some patients, but we require further studies and clinical experience before it is included in the guidelines. One last series which came from Japan was 85 patients were children and who required heart transplantation, and they did heart transplantation and liver transplantation together. Now, how do we diagnose what are the recommendations by Lipid of India? We recommend universal screening of all individuals prior to the age of 18 years or before they enter the college. Or you could do it earlier if there is a family history of familial hypercholesterolemia or premature coronary artery disease, so that we can detect it early, treat early, and prevent these problems. We recommend, of course, Simon-Broom criteria because it's easier. Cascade screening is essential, and you should include lipoprotein little a estimation in all your lipid screening. These are the radial targets in patients with FH. All patients with FH come in high risk. If it is heterozygous FH, he comes under high risk. His LDL goal is 70 milligram per deciliter. If it is HoFH, he is very high risk. His LDL goal should be less than 50 milligram. If they are associated with atherosclerotic cardiovascular disease, they fall into extreme risk category A and B, where you have to bring down the LDL cholesterol to less than 30 milligram. This is very difficult to achieve in most of our patients, but we should keep trying for it. So why FH is different? It is different because you never find an individual with FH. You always find a family. So you detect an FH, you have few more patients under your care. In conclusion, ladies and gentlemen, FH is a common and potentially lethal genetic disorder. Awareness has been suboptimal so far, but it is increasing. It continues to remain underdiagnosed and undertreated. It is easily diagnosed on clinical grounds. Cascade screening is essential. Therapeutic options are abound. Lifestyle intervention and control of other AST risk factors are important. We have a long way to go, as of course Robert Frost always said, roots are lovely, dark and deep, but we have a long way before we sleep. I gratefully acknowledge our Lipid Association, my departmental colleagues, Transfusion Medicine Department, Biochemistry Department, Pediatric ICU, Department of Gynae and Obstetrics, Management, and Charitable Minds, because we needed a lot of funds to carry out our lipoprotein apheresis, and my heartfelt thanks to our patients. Thank you very much.
Thank you very much, sir, for stressing on a topic that is less stressed upon, but is eventually very important in our day-to-day lives. It is only fair that a person with stature, as Dr. S.S. Iyengar, sir, is felicitated by two of our senior cardiologists. I request Dr. Ganesh Nallur Shivu and Dr. Deepak Krishnamurthy, sir, to felicitate our chief guest, felicitate our keynote speaker. Thank you. As far as keeping up on time, we are doing quite good by Indian standards as well as international standards. We'll have our next session at 7 p.m. sharp, short notice. The washrooms are right opposite. We are serving some tea in the corner. Please be back at 7 p.m. sharp. We have an international speaker from Venezuela. So see you at 7. Thank you.
Hello. Hello, can you hear me? Can you hear me?
Hello, doctor. Hello.
Can you hear me?
Yeah, one sec, doctor. We are just checking on the core system over there.
Okay, but can you hear me?
Zoom link तर
Thank you.
Hello.
Hello, check. Hello, hello, hello. Camera, yeah. Why you Okay, okay.
Hello, Zoom testing.
Hello?
Hello, Zoom testing. Hello,
Hello,
Zoom testing.
can you hear me?
Yes, doctor, we can hear you, doctor. So give us a minute, doctor. We are just testing the audio in the conference room.
Okay, perfect.
It's fine. Doctor, could you project to any one of slides? Can you share your screen?
I will. Okay, I am sharing my screen. Can you see?
Yes, doctor, we could see you. Hello. Oh, yes, put a no, he has dual screens. Ask somebody. Then we should pick this as a P. Already there. We'll ask them to. Dr. Swas, I think we can ask them to come back. Next session is going to start like that. Say you can say next 1 minute or a minute. First we need to. One minute.
We'll be starting the next session now. Everyone, please be back on stage. The topic for the next session is structural heart. And I request Dr. Chennayappan sir, Senior Consultant Cardiology, Ramakrishna Medical Center, Dr. Senthil Kumar sir, Executive Director, Chief Cardiac Surgeon, Kauery Heart City, Trichy, and Dr. S. Venkatesh sir, Lead Interventional Cardiologist, Aster RV Hospital, for chairing this session. The first talk will be a virtual session by Dr. Luis Manuel Creza Azencourt, interventional cardiologist, Centro Médico Docente La Trinidad, Venezuela. Dr. Luis Manuel specializes in structural cardiology and complex coronary interventions with over 280 successful transcatheter aortic valve replacements and a role as a proctor for Boston Scientific. He extends his expertise globally. Dr. Luis Manuel will be talking about cardiac embolic protection devices. Please, sir.
Good evening from
Hello,
India, Dr. Louis Creza.
Hello. Thank you so much for the invitation. It is a great pleasure for me to share with you today, even from distance. So for the next 15 minutes, I will discuss with you, talk about several protection devices, especially the Sentinel device, and the use during structural heart procedures. These are my disclosures regarding this presentation. And starting talking about epidemiology of TAVR-related stroke, we can see this data from the STAs and ACC registry. More than 100,000 patients in US. We can see that the rate of strokes 30 days is 2.3%. Also, we can see that the majority of the strokes occurs within the 72 hours after the procedure. So it's an event related with the procedure of TAVR. We can call the TAVR-related stroke like an unmet need for TAVR procedures. Because if we see other events that can occur after TAVR, for example, conduction disturbance requiring pacemaker implantation, we can see that advanced technique reduce the incidence of these events. Also, we can see vascular complications during time reduced with the use of closure devices, low-profile sheaths, and even mortality decrease over the year. But when we talk about a TAVR-related stroke, we see that over the year, the rate of this event remains unchanged. It's something that even the technologies, the new generation of devices are going further, the stroke doesn't change. And we see that rates of events between 2 and 2.5% unchanged during the years. Also, we can name the TAVR-related stroke like a catastrophic event for TAVR patients, increasing the risk of death, need of gastrostomy, mechanical ventilation, and tracheostomy. So it's even if the rate is not too high, it's a catastrophic event for the patients undergoing TAVR. How this event can occur during the procedure, it can occur 3 stages. First, crossing the aortic arch with the delivery system and the valve we're going to implant also can occur because the manipulation of the valve, pre-dilatation, and even the implantation of the valve at the level of the annulus of the patient. Remembering that this annulus or this anatomy is extremely calcified in the majority of the patient, and some debris can embolize to the brain. And the second time stroke can occur is the late stroke. The majority of the cases related with atrial fibrillation, which also is common during the TAVR procedures. This is how the procedure with Sentinel device, the protection of cerebral protection is done with Sentinel device. First, we use right radial access, and we implant the proximal filter in the brachycephalic branch. Then we deflect to the deflectation of the catheter, cannulate the left carotid artery and place a distal filter. Then we do the procedure as usual, keeping the filter in that place. And when we end the procedure, we take off the filter. Remembering the brain irrigation and the clip we just saw, we need to remember that 90% of the irrigation of the brain come from the brachiocephalic arch and the left carotid artery. 10% is by the left vertebral artery. So if we remember that we have two filters, one proximal and one distal, covering the brachiocephalic branch and the left carotid artery, we have this 10% of the cerebral irrigation that is not protected with this device. Also, it's important to remember that when we talk about TAVR-related stroke, we can have clinical events or disabling stroke, but also we can have subclinical events which might be important, especially in low risk or younger patients, such as dementia, depression, cognitive impairment, or even issues with memory. So embolization to the brain is not just the clinical events, the stroke per se, but also the patients can get subclinical events in long terms, and this is particularly important for the young low-risk patients. So when we talk about this, the TAVR protected TAVR, we can ask the question: who patient we most protect the most, or which patient are we going to use the device? Here I put those two examples. First, we have intermediate high-risk patient, old patient, more than 80 years old, and on the other hand, we have a low-risk patient as mid-Jagger. So which one of these is the patient that will, if we have to choose, we will use the Sentinel device? And probably the answer is another question, is who is at higher risk? Who will have more benefit of using protection devices during TAVR? Trying to answer that question, there was a trial presented 2 years ago. It was named Protect TAVR trial. It was a trial with two arms, a randomized trial with two arms, comparing TAVR without protection devices and TAVR with Sentinel device. About 1,500 patients for each arm. And the primary endpoint for the trial was a stroke at 72 hours or at the time of discharge of the patient, comparing the two strategies. The results of the trial showed that there was nothing statistical significance difference between using or not using the device in terms of all strokes, which was the primary endpoint of the trial. But it was a significant difference in favor of using the device in terms of preventing disabling stroke, which probably is the most important clinical event in this kind of patients. So there was no difference for all stroke, but there was different in preventing or reducing the rates of disabling stroke. Here we can see the reduction of relative risk of all stroke during the first 72 hours was 21% of relative risk reduction. And as I said before, the rates of disabling stroke were statistically low in the Sentinel arm, which represent 60% reduction of relative risk for disabling stroke when you use the cerebral protection device, in this case Sentinel device. So the conclusion of the trial presented by Dr. Kauery from Cleveland Clinic was the use of Sentinel device was feasible in more than 94% of the patients without any complications. The protection device did not reduce overall periprocedural stroke, but it reduced the disabling stroke, specifically ischemic stroke. And also it's important that not a specific groups of higher risk were identified in the trial. Maybe the reason of this was because the majority of the patients would probably are at highest risk of the stroke, such valve valve or bicuspid aortic valve were not so much included in the trial. Below the 5% of the patients were valve valve or bicuspid or string calcification valve. When I said at the start of the presentation regarding the unchanged rate of stroke related TAVR over time, we can see that some single centers experience showing the opposite. In this slide, we see the Cleveland Clinic experience in which we see from 2013 to 2020, the increase of the procedures using cerebral protection devices, over 90% of the procedures. And at the same time, we see how the stroke risk reduced from over 2% to around below 1%. So as the use of cerebral protection devices increase, the stroke rate decrease. And this is, as I said, a single center experience, but we can see this behavior in many other publications from Europe, and from US. So after the results of the PROTECT TAVR, there are still remaining questions. Before the trial, we have three groups of physicians, those in favor, those against the use of the device, and others who don't have enough data to take any decision regarding that. And the fact is after the result of the trial, I think these three groups remain the same. There are some remaining questions still need to be answered. And for that, maybe we will need to wait for the results of the British PROTECT TAVR trial, which is a trial with more patients enrolled, and also probably they will enroll patients with more risk, anatomical risk of strokes. Now I want to share with you some real world patients from my own. I will just comment 3 patients. The first one was a patient with thrombus in the apex of the left ventricle. So I think in this patient there is no doubt if he needs TAVR, and you are going to place a wire inside the left ventricle, the need of using cerebral protection device in this patient is quite clear, at least for me. So we use it, and that's what we obtain in the filters. The second patient is a patient who is with a string calcification of the anatomy extended to the LVOT. Also, in this patient, we can say that probably is at higher risk for presenting a stroke. Also, the Sentinel device was used, and that was with the filter cup. And this last patient was, we can say, a usual patient. We decided not to use a Sentinel device, but what happened after predilatation was this, as you see, the calcium of the leaflets moving after predil, and 24 hours after the procedure, the patient had a stroke in the cerebellus. So in conclusion, my take-home message from this conference is the use of cerebral protection devices prevent disabling strokes. That was demonstrated in the PROTECT TAVR trial. The use of cerebral protection devices should be considered in all patients undergoing TAVR if we want to reduce disabling strokes. And since the safety of the devices has been established, the cost of consideration may be an important issue when taking the decision of using or not using cerebral protection devices in TAVR procedures. Thank you so much for your attention.
Thank you, Dr. Krisa. That was a very comprehensive talk on the subject, cerebral protection in TAVR. I suppose there is true equipoise today about whether to use these devices in all patients or select patients. As you rightly pointed out, cost, especially in a country like ours, becomes a very important consideration. Any comments from the hall, Dr. Anantharaman?
Thank you, Dr. Krishna. That's a fantastic summary and talk. We need to know the limitations. At the moment, we don't have a device which gives 100% protection, full stop, because this gives 90% protection. The limitations, you need a right access, right radial, right brachial. So if you have a dialysis patient with AV fistula, it's no-no. If you have difficult tortuous anatomy on the carotids otherwise, it's a no-no. And if you have bovine arch, it's not licensed for use. So using for all TAVI patients to protect stroke at this point in time, we don't have a device. What we have is this one. This is the best we have. It does add to the cost. And the evidence, as was shown, the primary endpoint was not met. What was met was disabling strokes was reduced. So in terms of using it, yes, it's got a place. In patients, at the moment, we don't know which patients will benefit, which we do not. So if patient can afford in India, and if the anatomy is suitable, and the only device that is approved at this point in time is the Sentinel device. There are new devices which is coming up, which will be available in the next sort of couple of years' time, which will give 100% protection. So clearly, obviously, for reducing disabling strokes, we need a much better device. Ajit?
Yeah, I think more important take home, I would say, is actually choose your patients. Like you use intravascular ultrasound in a PCI. In a country like ours, we are not kind of luxurious enough to use imaging for all our PCA cases. But the take home message should be choose your patients, those patients who have a high risk anatomy, at least offer them the advantage of a Sentinel device, like a valve-in-valve, like severely calcified, previous stroke. And the example like he showed, like already there is a thrombus in the left heart. So these will be the cases where at least we would be using this device. And as Anand was telling, cost is a major constraint. But then again, sometimes a debilitating stroke, especially when we know that the risk is prohibitively high. I think these patients would be definitely be using. Yeah, thank you.
I think the Cleveland Clinic data is a single center. And also, I suppose from the timeline, there is improvement in device technology, and obviously the operator experience would have gone up. So I'm not very sure whether we can use that to,
Because there are some centers who are actually religiously doing that. One is Cleveland. I think Samir is using all of his cases. Actually, it's 100% penetration of the sentient device. There are certain operators by default use embolic protection for all their TAVI cases. I think operators like us who do India, we are very cost-effective TAVI packages we offer, and I think we have to be, and data also is, you don't have a level 1 evidence to use this. I think we have to pick our choose patients. Like I mentioned, like we use imaging for all our left main cases, all of these high-risk anatomy cases. I think that will be the way to go. And she'll wait for evidence to come and wait for much more cheaper devices to come.
Dr. Prasad, in your experience, you have said you would like to use them in most of your patients or all patients. Is there any particular subset where you would be really happy to use them and not avoid using it?
Yeah, actually, as I said, I try to use in the majority of the patients. But it's important, as you mentioned, we have to consider the feasibility of using the device in terms of the anatomy of the patient. For example, if you have a patient with tortuous anatomy, string calcification, bovine arch, probably the use of the sentinel in these subsets is not recommendable. But I take in count the risk of the patient for having a stroke. For example, as I said, I consider patient at high risk for stroke, valve-in-valve, string calcification of the leaflets, the valve of or the LVOT, and also bicuspid valves. Maybe in this subset of patient, I really use in 100%. I probably choose not to use when the patients have some challenging anatomy that maybe can put in risk or take the procedure longer than usual. And also it's important, we cannot make what we are going to prevent. So if we have a challenging anatomy and we are manipulating so much during the deflection, cannulation of the carotid artery, probably it's better not to or to abort the placement of the device. So in summary, I think we have to consider on one hand the risk of the patient, but also on the other hand how challenging the case will be. The mean time for placing the sentinel device should be 4 or 5 minutes, no longer than that. So if we have an anatomy or a special patient that we are taking 10 minutes, 15 minutes to place the device, it's better to abort and continue with the TAVR procedure.
Thank you. Are there any other questions from the audience? So thank you very much, Dr. Prasad. Thank you for joining us and being with us today.
Thank you so much for the invitation. It's a great pleasure, and thank you so much.
Thank you, sir. Thank you. Next up, we have Dr. Chiran Babuye, Senior Consultant, Cardiothoracic and Vascular Surgery, Kauery Hospital, Bangalore. With over 2 decades of experience in cardiac and vascular surgery, sir is experienced in investing. Has a significant experience in harvesting aortic and pulmonary homografts for cadaver hearts, with special expertise in minimally invasive cardiac surgery and valve repair and replacements. Over to you, sir. I also request Dr. Deepak Krishnamurthy and Dr. Vivek sir to panel the panelists for the talk. Thank you.
Good evening, everyone. Today I'm going to give a brief overview about the mitral valve. The topic which was given to me was surgical mitral valve repair. I didn't want to change that heading. I would love to put reconstruction instead of repair. I'll tell you the reason why. What is the rationale for mitral valve repair or replacement? Any valve, as a matter of fact. Particularly more so with the mitral valve, because there's a better preservation of the left ventricular function, avoidance of a prosthesis-related complications like hazards of over and under anticoagulation, stroke, endocarditis, degeneration of bioprocesses, poor patient complications, and a need for redo surgery. This translates to reduced morbidity and the length of stay of the patient in the hospital, reduced in-hospital mortality, and an improved long-term survival. Now, coming to the mitral valve anatomy, why I would prefer a term reconstruction. Mitral valve means it's not just two leaflets and an annulus. It encompasses all these entities, mainly two leaflets, the anterior or the aortic leaflet, posterior or the mural leaflet, the commissures and the commissural leaflet, the zones of coaptation, the entire mitral annulus, the subvalvular apparatus, which encompasses chordae tendineae, the papillary muscles, and the left ventricular wall, and the valvuloventricular interaction. The entire thing will come into the picture when a patient is contemplated for a mitral valve reconstruction. Now, coming to the leaflet classification, it's broadly into the anterior mitral leaflet and the posterior mitral leaflet. It's got two commissures, anterolateral commissure and a posterior medial commissure, and two papillary muscles, anterior and a posterior. There is a single or a solitary line of closure, which you can make out here. There are scallops or slits in the mural leaflet, that is a posterior leaflet, which helps in the unfurling of this leaflet. What is the zone of coaptation? The zone of coaptation, the anterior leaflet as well as the posterior mitral leaflet contains two zones, a smooth zone and a rough zone. The smooth zone where there are it's devoid of all the caudal attachments. The rough zone is the area where the chordae are attached. And this rough zone contributes to the height of the coaptation, thereby that translates to a successful mitral valve reconstruction. For all practical purposes, I'm going to deal with only mitral regurgitation. Mitral regurgitation is a common mitral valve pathology. The etiology can be congenital, rheumatic, infective, degenerative, myxomatous, and functional. This is the etiology. The pathophysiology can be an isolated stenosis or a regurgitation arising out of this pathology, or a mixed lesion. That's a mitral stenosis as well as a mitral regurgitation. Before we embark upon the mitral valve reconstruction, I would love to mention about this Carpenter's classification for mitral regurgitation, wherein the leaflet motion plays a very significant role. It's classified into type 1, type 2, type 3A and B. Type 1, there is just an annular dilatation with normal leaflet morphology. Type 2, there is a leaflet rupture, or without rupture, it can prolapse. Type 3A, where the leaflet motion is restricted because of the leaflet pathology or the mitral valve subvalvular apparatus pathology. Type 3B is due to the pathology of the ventricular wall. Then why repair is not commonly opted for or done? Because, like I told you, the mitral valve encompasses multiple components. So you will have to address at multiple levels the problems to get a competent and a successful repair. So it takes a lot of learning curve to get a good grip of these multiple components involved in a successful repair. And it takes a little bit more longer time. So that is one of the main reasons why repair is not commonly adapted by people. Now, coming to the congenital mitral regurgitation, I'm going to show you two simple cases of congenital mitral regurgitation, which we have done. The first case is a 5-year-old girl diagnosed with severe mitral regurgitation at very early age. When she came to us, she was around 5-year-old. Probably around 2.5 to 3 years, this mitral regurgitation, congenital mitral regurgitation was diagnosed, and she was running from hospital to hospital. And she was told that let the child grow to a certain age, then she can undergo surgery. But the patient was extremely symptomatic. And what pathology was noticed in this patient was a congenitally elongated abnormal papillary muscle. Sorry. This is the congenitally elongated papillary muscle, which can be made out, wherein the normal papillary muscle will be flesh-like. Here you can see that this papillary muscle is almost whitish, fibrotic. What we did was, we plicated the papillary muscle using a 5-O-proline, and this is a pericardial buttress to prevent the cut through. And then, since she was a kid, we did a posterior Teflon annuloplasty. Coming to the second case. This is a congenital double orifice mitral valve. A 9-year-old boy referred for repair of the mitral regurgitation. He was found to have double orifice mitral valve. The challenge was only one orifice had regurgitation. The other orifice, the leaflet coaptation and the coaptation height was normal. I had to currently identify and repair only the one orifice which was leaking. You can make out here the forceps in the two orifices with a ridge of tissue in between them. This valve was repaired by the commissuroplasty and followed by a posterior Teflon felt annuloplasty. Now, coming to the second subset, I've put it as a second, the rheumatic mitral repair, because still we see significant number of patients with rheumatic mitral valve disease referred for replacement. But still repair holds a very good, you can consider repair in a very good subset of patients who have rheumatic mitral valve disease. And to quote, this is one of our Indian studies only from All India Institute of Medical Sciences, Professor Sampath Kumar's, a 2006 study where 898 patients were studied, who were almost like 50% of them were pure MR, 45%, 55% had a mixed MR-MS. Of this 898 patients, the leaflet prolapse was there in 30%, annular dilatation in almost 80%, with calcification noticed in around 4.3%. And the interim results of this study showed that at 10 years, there was 70% freedom from reoperation. Okay, what does surgical procedure entails in a rheumatic mitral valve reflex? There is an inflammatory membrane which you can see over the anterior mitral leaflet. You can see that usually mitral leaflets are very thin, papery-like substances. We have peeled that membrane from the base of the AML towards the tip. And this is the inflammatory membrane. You peel this membrane, followed by resection of the thickened and fibrosed secondary and tertiary chordates in order to mobilize the leaflets. And if the PML is short, you augment the PML or an AML, and then this is done to create a optimal coaptation height, where you can see here. The PML was very short in this patient. We augmented with a strip of autologous pericardium, treated pericardium. And now you can see a beautiful coaptation line, which is towards the posterior. Now, coming to the myxomatous and degenerative mitral valve diseases. This is an entire, both these entities are a spectrum of mitral valve diseases. It starts with a degenerative mitral valve disease and ends with myxomatous mitral valve diseases. Heterogeneity of pathologic anatomy is the pathognomonic feature of this entity, wherein this entity will see 16% the dilated annulus, elongated chorda in 24%, and the caudal rupture either anterior or posterior in 5%, anterior caudal rupture in 6%. Majority, that is 49% of these patients present to us with posterior leaflet caudal rupture, that is 49%. And durability of mitral repair for degenerative disease has been very well established by Dr. Alan Carpentier. This EPIC paper, which is published in 2000, 162 patients with a follow-up of more than 20 years for non-rheumatic MR. This is 74% freedom from cardiac events at the end of 20 years. Till this day, this remains an EPIC study in the mitral valve repairs. So, after the Carpentier's classification, he's the one who coined the French correction for mitral valve repairs. What is the aim or the basis of the French correction? It restores a normal valvular anatomy that entails resection of the leaflet tissue, caudal manipulation, followed by a rigid annuloplasty ring implantation. What things are performed? Leaflet resection and caudal manipulation. A quadrangular resection, sliding annuloplasty when the leaflet tissue is excess, caudal transfers are shortening, papillary muscle plication like you saw in the congenital papillary muscle elongation. In contrast to this French correction, there's another entity, American correction, where it is minimalism. Very minimal or absolutely no leaflet resection, liberal use of artificial chordae, and a flexible annuloplasty ring implantation. Wherein this study from Baylor Hospital in 2006, 152 patients, where they have achieved a 90% repair rate for all MRs, mitral regurgitations, and a 100% repair rate for degenerative mitral regurgitation, wherein they didn't do any leaflet resection. It is respect rather than resect. This is another case where we had done in a patient with a long-standing myxomatous mitral valve disease with posterior annular calcification, a 42-year-old male, chronic MR, delayed presentation with posterior mitral annular calcification. you can see the chunk of calcium sitting there in the posterior annulus. That's a severe MR. It was a complex repair. The entire posterior leaflet was detached from the mitral annulus. The decalcification was done. Resection of the scallop of a PML, which was prolapsing, and it was enlarged. And PML sutured back to the mitral annulus, followed by a rigid ring annuloplasty. And we even added a no commissuroplasty was added. And this is the lump of calcium which was removed from the posterior mitral annulus. This is a scallop of the prolapsing posterior leaflet which was excised. This is a post-op echo. No MR. And coming to the mitral valve repair for endocarditis. Endocarditis is a very heterogeneous disease. The disease process can involve the valve, annulus, and the extent of tissue destruction, whether it is an active disease or a healed vegetation. And most patients with mitral valve endocarditis, either it is active or acute or a delayed or a healed vegetation, can be successfully salvaged with mitral valve repair. A short note about the ischemic mitral regurgitation. In ischemic cardiomyopathy, there is papillary muscle displacement followed by annular enlargement leads to mitral regurgitation. Here, most important thing is we have to assess the patient and see whether the patient will benefit from doing other concomitant procedures rather than trying to directly jump onto either repair or replace the mitral valve, like coronary revascularization, and it should be a complete revascularization, and a mitral valve repair if it is just a functional regurgitation of up to grade 2. Any regurgitation beyond grade 2, the success rate of a repair in the long term will definitely be on the lower side. And if there is a myocardial scar in the right coronary or the circumflex area, definitely that patient is not a very good candidate for a repair, rather than replace the valve with a tissue valve. And obviously the percutaneous procedures. This is an interesting case. This is an elective case which was referred to us, wherein this patient came in a subacute presentation with mitral valve, mitral regurgitation, wherein this patient on table we detected that the patient had a papillary muscle head rupture of one of the heads from the posterior papillary muscle, leading on to severe eccentric MR. And we excised that papillary muscle and put in an artificial neochordate, 2 neochordates, followed by a complete rigid ring. And the same procedures, the mitral procedures, are being done with minimally invasive procedures like partial sternotomies, upper partial sternotomy, lower partial sternotomy, and thoracotomies without chest spreading, totally endoscopic, and even robotic surgeries. This is a 26-year-old female presented with a severe mitral regurgitation, myxomatous mitral valve with AML prolapse, where we prepared this chordae on table, and then this was implanted to the anterior papillary muscle and fixed to the AML was shortened. And this is the end result. Thank you. Sure, sir.
Very happy to listen your talk. I hope you understand. I'm very happy to listen your talk. I'm Dr. B.J. Murthy, General Surgeon.
Thank you, sir.
General Surgeon. So I want to narrate one patient, my own relative. Exactly 1 year back, he had second heart attack. For the first heart attack, nothing was done, nothing was necessary. Second heart attack, they have done an animal valve replacement. I wanted to ask you a little more questions, or I wanted to have your own opinion and a little more description. Exactly 1 year back, he was operated. He became all right. Now he's doing very well. He's about 65-year-old. And the same evening, unfortunately, apart from animal valve replacement, reconstruction of artery also was also done. Arterial reconstruction was also done. Unfortunately, this happened in the morning around 12 o'clock. Midnight, he had severe hemorrhage. He had to be reoperated and corrected. So I wanted to know more details about animal replacement, animal heart replacement.
I think what you're quoting is a bioprosthetic valve, sir. That is tissue valve or bioprosthetic valve. Usually the valve is not repairable. In a 65-year-old patient, the guidelines say that they should receive a bioprosthetic or a animal valve like you're telling. That is the guideline. I couldn't get your question, like what do you want to know from me?
I wanted to know more information about animal valve replacement to the general public.
Okay. See, the repair is the best option, like I told you. If it's not a repairable valve or a salvageable valve, there are two options available. One is a metallic valve or a mechanical valve. The other one is a tissue valve or a bioprosthetic valve. There are two options when we consider a tissue valve. One is a porcine valve. The other one is a bovine pericardial valve. Okay. The mechanical valve are all standardized. Nowadays, the porcine valves are less preferred compared to the pericardial tissue valves because the longevity of those valves are much better in the when we implant them. And the second generation and the third generation valves of these bovine pericardial tissue valves have got a lifespan of up to 12 to 14 years or 15 years. The current generation of the Edwards tissue valve, both in the aortic and mitral position, they say it's beyond 20 years, but it's too early to celebrate that thing because that valve is in the market for only last 8 to 9 years, wherein the interim results say that 98% freedom from reoperation at 8 years.
Why sudden hemorrhage in the midnight?
So sudden hemorrhage has got nothing to do with the valve replacement. Sudden hemorrhage can happen after any open heart surgeries or any, as a matter of fact, any heart surgeries. Because we use high dose of blood thinning medication, that can be one of the causes. Or when we cut into the heart, we suture it back using monofilament sutures. If that sutures cut through or become loose, the patient can bleed from such sites.
Thank you, Charan. I think we can go for the next talk. And if there are any further questions, we can take it together because he's also going to talk about mitral and aortic valves.
So please wait. I request our panelists to give a token of appreciation to Dr. Chiran Babu, sir. I now like to invite Dr. R. Anantaraman, sir, Senior Consultant, Interventional Cardiologist, Kauery Hospital, Alvarpet, Chennai. Having published multiple papers in reputed peer-reviewed journals and pioneering many unique interventions, he showcases his expertise in hypertrophic cardiomyopathy, transcatheter heart valve therapies, stem cell therapies, and rotablation. That's it.
Good evening all, and sincere thanks to the organizing team as well as Dr. Chandrakumar sir and all the Kauery family. It's a pleasure to be here. Obviously, we had fantastic talks from my colleagues on surgical mitral repair, the developments on the transcatheter side, simultaneously has been exceptionally good. There are patients who cannot have surgery, and there are patients who have had surgery who need further set of treatments. So we have got multiple transcatheter options, and it's growing all the time. I'll share some cases and I'll show you what is coming up in the future as well. Yeah, so first I'll talk about the patients who already had surgery. So mitral valve interventions in patients who already had surgery. Surgery means whether they had a ring. Sometimes the surgeons will repair with the annuloplasty ring. Sometimes they will replace the valve with the bioprosthetic valve. That was the colleague was asking. Sometimes there will be mitral annular calcification, and sometimes there will be previous surgical repair, but they will have leak. So how do we deal with these patients when they come with further issues, if the ring is failing and leaking, or if the valve is failing, or any of these issues? You need a good imaging to confirm the diagnosis. And the second thing is a good CT scan to plan your case. 90% is case planning, only 10% is what you do in the cath lab. So for all structural, a good diagnosis to make sure that your valve is only leaking in the valve, not paravalvular leak, and a good CT scan. In the CT, the mitral valve interventions, mainly we look for one major thing, that is the valve we are going to put in the previous surgical valve or ring, it should not cause an obstruction to the left ventricular outflow tract, because those two are very closely associated. That is your mitral valve, that is your left ventricular outflow tract. That's very, very important. So the CT will give you that assessment of how much the LVOT, left ventricular outflow tract is, that is the neo LVOT after we put the valve. So that's the main purpose of doing one CT scans. If your neo LVOT is going to be less, we have multiple other options in terms of dealing with that. We can lacerate the anterior mitral leaflet, we can do septal ablation, multiple things are there. So if the septum is hypertrophied, we can do septal ablation. If the mitral valve anterior leaflet is coming on the way, we can lacerate it without surgery. So with that, I'll show some cases, 3 or 4 cases, and then I'll go to the mitral regurg. So mitral valve in ring, a mitral valve in valve. So the mitral valve in valve, you confirm the diagnosis, you do a CT scan. In the cath lab, a good transeptal puncture, because you need to cross from the right side to left side to do it. You need a good transeptal puncture. You cross, you put a wire, you deliver a valve, and the patient goes home at 48 hours. And this is how we do it. A 77-year-old, previous CABG, previous mitral valve replacement, multiple other issues, now coming with again further same problem. So this is a tissue valve, animal valve, bioprosthetic valve that is failing now after 10 years. How we do that? We do the CT scan, as I said before. Specifically, you assess the neo LVOT. The neo LVOT is here much higher, more than 400 plus. So you are not worried about the obstruction. You have simulated the valve. It's very simple procedure. The first picture shows that I'm crossing from right to left. So there's the needle, there's puncturing. So once we cross from the right to left, we put a catheter. There's a catheter from going to right to left. And it's ultrasound guided. As I said, it's very important. You get the puncture at the right point, inferior, posterior. Yeah, that's a nice puncture. And then that's your tube. There's a wire. Over the wire, you take a balloon first, and you dilate that interatrial septum, a 12 or 14 millimeters balloon. So that's what it's being done. You can see the balloon going up, and it's opening up the septum. After that, you take a balloon expandable valve. That's a balloon expandable valve. Position it, rapid pacing. You deploy it slowly. And there's a procedure done. It's a venous procedure. You close the groin on the patient. Immediately, the valve starts functioning. And the patient can go home within 48 hours. And that is after the procedure, there is no gradient. So it's the simplest of the procedure. It's much simpler than a transcatheter aortic valve replacement. Now, with regard to mitral valve ring, when surgeons put a ring, this is the first case in India of a physio ring that was done. How we do it, that's a surgical valve. You can see there's a flyer leaflet with a lot of leak in that. There's a subtle difference on how we do with this case. Planning, access, all the other things are same. The neo LVOT is fine. We are just running up and down and seeing the neo LVOT. This is exactly what we do with the CT. But the most important thing is you need to know what ring the surgeon has used. If the surgeon has used a semi-rigid ring, the semi-rigid ring will become circular, and also it will give good anchoring. So that is the best ring. So in your unit, if a surgeon is doing a mitral valve repair now, ask them to put a semi-rigid ring, so that future for us, it becomes very easy. You get a fantastic result. If they put a rigid ring, it will give anchoring, but on either side, you will have a hole. You will get paravalvular leak. If you put a complete band, it will give ankle, but circularity, but it may not be the best. If they put an incomplete, it's no use. So ask them to put a semi-rigid ring, and this is the best thing for the patient, so that future, they don't need to have another surgery. We can go and deal with that. So general anesthesia, transeptal puncture is the same, exactly the same as the last case I showed. You cross over, wire, and very, very important, a very slow inflation, because the valve will tend to go in, so you drag it back, 80% deployment. Once 80% deployed, you push it to the roof, because you are literally here putting a valve within a very thin ring, so you don't want to slip. So that's how it is done. It's almost 30 seconds to 1 minute, rapid pacing, almost a heart is stand still, and immediately it will pick up. And that's how it looks. As soon as you put, it starts functioning, there is no leak, and the 3D echo shows a fantastic coaptation. So this is as good as it gets in terms of your procedural satisfaction and the patient's outcome satisfaction. So the key message, both can be done. You need to select the patients, you need to plan, and you need to have the assessment done properly before you go into the lab. If the surgeon has put both aortic and mitral valve, or even 3 valves, can you do something if the patient comes back with the failure? Yes, 82-year-old, both valves failed, aortic and mitral failed. Specifically, the heart function is 15%. You can ask, why do you want to do something about in this 82-year-old? He's been very fit and he wants to live longer. So he also has a heart block. How do we deal with this? Exactly same. You get access, both right side and left side. Usually I tend to put the puncture, right atrium to sort of left atrium, keep your wire, then you give the full heparin. Then you go and put the aortic valve first. So that's the previous surgical valve. We are putting an aortic valve in valve. This is called valve in valve. That means we are putting a new valve in a previous surgical valve. Once that is done, your access is already there for the mitral. You go and put a mitral. So aortic valve in valve, mitral valve in valve, and for the patient, because he's having heart block, you go and put a pacemaker inside the heart. That's a micro pacemaker. And the patient goes home in 48 to 72 hours. So these kind of very high risk patients, this was done in May 2022. The patient is doing well. He was in NOHA class 4, now he's in NOHA class 2. He's got a big form in Coimbatore. He walks around 4 kilometers. So that's how it looks. So these procedures can be done safely, and the cost is coming down, and safety is much, much, much higher. If you have the mitral valve problem with obstruction, LVOT obstruction, you can lacerate the leaflet. I'll just skip through quickly. So this one specifically had a neo LVOT of 130, potential obstruction. You lacerate the leaflet. It's called electrocautery. You have a continuous system, one catheter here externalized, and it is in the leaflet. Basically, you cauterize from the outside, cut the leaflet, put the valve, and it functions immediately. So all this is possible. Now, this is all for the previously placed valves and other things. What about mitral regurgitations? Mitral regurgitations, my colleague has already talked about the repair. There are multiple transcatheter solutions coming up. This has already been discussed in detail. Mitral valve is a specifically complex valve. You've got the atrium, you've got the annulus, you've got the valve leaflet, cardia, papillary muscle, and the left ventricle. Any of this going wrong will cause mitral regurg. You need to deal with all of them separately. So functional mitral regurg, as well as degenerative. Degenerative is the valve problem. Functional is mostly the left ventricular problem. We can deal with that as good as surgeons nowadays. All these three are possible. Leaflet resection is not possible at the moment, but it will be possible in future. So it is coming up. So what we do, I'll skip there. We have got this clip, which is like the Alferi stitch. We go and make the mitral valve into two orifices, and the regurg disappears. And there's two devices. One is the mitral clip, the other one is a Pascal. The results are looking good, and both the devices are comparable. With regard to the secondary mitral regurgitation, if there is a problem with the valve, that can be dealt with the clip as well. And the mortality benefit is there. We've seen that. Now, challenges. There are challenges if you have calcification, if you have fixed leaflets, if you already start with a small mitral valve area, tethering, all these are challenges. For this, solution is total mitral valve replacement percutaneous without surgery. And that is coming up, and that will be fairly soon. We'll see that. I'll skip this for the purpose of time. This is one of the half-moon device which is coming up. Annuloplasty is possible, but it's not as good as the surgical annuloplasty. So we do have challenges. We do have transcatheter options available, but these are options for patients who cannot have surgery. Now, with regard to tricuspid, sorry, these are the total mitrals which are coming up. The promising devices seems to be the Interpede, as well as the Tendyne and the Evoque device. It's gone through first phase studies. It looks good. So hopefully in the next sort of 3-4 years, we will see that here. Now, with regard to the tricuspid, it's even more complex. A lot more associated structures, a lot more conduction abnormalities, issues will be there. So the tricuspid, total tricuspid replacement will be here very soon, more before the mitral. So you assess the TR, you assess the symptoms, assess with echo, you give adequate medication. In spite of that, if they're still having right heart failure, then you do a right heart catheter and also all the laboratory. But the first thing is, you discuss with your surgical colleague first. If the surgical risk is acceptable, send for surgery. If there is no surgical option, then there are multiple transcatheter options available. I'll skip this. The tricuspid is different. As such, tricuspid regurgitation, the primary is less. Majority of them are due to the other reasons, especially with the cardiologist putting more and more leads, you get secondary tricuspid regurgitation. So depending on your, whether it's functional or whether it's secondary, we have got multiple device options. You can go through SVC, you can go through IVC, you can come directly to transatrial in some cases and do this with safety and good efficacy. Multiple devices are there, multiple devices coming. We've already seen MitraClip. It can be used in the tricuspid. Now we have TriClip. Pascal can be used. So clipping can be done in the tricuspid position. You can do annuloplasty. And if nothing is possible, if the patient is end stage, you can put an IVC SVC valve that is called a heterotropic or a trick valve. So I'll skip this for the purpose of time. I'll just go to the last couple of slides because now this is what is coming. Now the FoldX valve is coming. The first surgical part of the trial is over. It's done in Mumbai. It's supposed to be not degenerating. It's supposed not to need anticoagulation. So we may not need to do any of the other procedures said if this works for 20, 30 years for a patient. In terms of training, this is what is coming up. You don't need to imagine things now. You can go into this lab, you can put your VR, you can see, you bring the heart in front of you, valve in front of you, and do all this sort of repairs and trainings with these things. And all this kind of is possible. It is coming up, and we are trying to set up labs for training people adequately. With that, as Martin Leon says, the structural heart is an exciting new playground for interventional cardiologists, but a good heart team that includes a good surgeon, a good imaging specialist, interventionist, and patient is very important. Otherwise, your sort of program will fail. So make sure you have a good heart team, you discuss, and you work as a team. Thank you.
That was an excellent talk, Anantram. I would invite questions from the floor. No questions? I just have one question. See, you said there are newer valves coming up for mitral position or normal mitral position of the MR. Can you just give me some more information about that?
Yeah, obviously you're a fantastic surgeon, so you'll understand how complex the mitral anatomy. And if you want to put something in the mitral, first you need to have an anchoring system. Then you need to have a leaflet that will work. Now there are multiple technologies have been tried out, various baskets, anchors, various things. The initial problem was the size. It was all like 34 French, 42 French, huge catheters. Initial procedures were transapical as well. Now, gradually now the systems are getting better. They're getting down to about 24 and 26 or 22 French. We are able to deliver it through the right side transeptal with the basket or anchoring, different anchoring systems, and then you deliver the valve through that. Now, the three I mentioned, the Tendine, the Interpede, and Evoke, they looks promising. And it has got its shortfalls. Too large devices, at the moment it becomes difficult. So an acceptable 25 to 28 annulus, whatever it is, if it's failing, then these devices will be available and will be possible. The tricuspid seems to be a little bit more forgiving, and tricuspid may come first before the mitral, before the total mitral.
Yeah, thank you. And regarding the valve-in-valve, are there any particular valves right now in the market which are specifically designed for valve-in-valve implants?
Yeah, absolutely important question, because now that we are moving the age, I think my previous colleague said previously 65 was the cutoff for metallic versus bioprosthetic. Now we have almost moved to younger ages. So if you're going to put in the younger ages, the valve that will slide open with the bioprosthetic that is available. The other valves, when you put it, make sure in your unit you put it so that we can fracture it, especially if you're going to put a small valve, a 90 millimeter valve. Certain valves are fracturable and certain valves we cannot fracture. I was just having this discussion with my colleague, Dr. Agram sir there. So some of the valves are fracturable, like EPIC, and even the Indian made daffodil, those can be fractured. So in our own unit, I think we are looking into that and we are putting these valves so that when the patient comes back, we can fracture and put an adequate valve. So as a working group, surgeon and cardiologist need to sit down and discuss and decide what bioprosthetic valve you're going to use in your unit so that future sort of TAVI safe and TAVI safe.
Excellent.
So one question regarding the lead-induced TIA. How do you manage them? Symptomatic patients, severe TIA?
Oh, most of the time, you need to have a good assessment because there is always a secondary and a primary pathology in these cases. So you need to assess properly. And these cases can be clipped or can be sort of having atrophic valve as well. Now, there is always a worry about if you put something in the tricuspid valve with the leads and it doesn't cause any problems. So it should be fine.
Thank you, sir.
Sir, just for curiosity, aortic and pulmonary also, is it done similar way?
Sorry, where? Oh,
Sir,
sorry. Yeah.
Just for curiosity, aortic and pulmonary can be paired like this, same way?
Pulmonary also we do it, sir. Pulmonary we do it. I didn't show it for the purpose of time. Normally the pulmonary means there are two different pulmonaries. One is the adult congenital ones where the surgeon would have done a native right ventricular outflow tract repair, RVOT repair. And when that RVOT repair patient comes, multiple surgeons do it different ways. They are very big. And when these RVOTs are large, the currently available devices are not such that we can accommodate. But if it can accommodate, we tend to put a stent first. Pulmonary is a forgiving position. You can pre-stent even if there is free PR, nothing will happen. You can go back and put a new valve. One of the balloon expandable valves I showed, you can go and put it. There are dedicated valves available. The venous valve is available. And also there are dedicated baskets with valves are coming up for the large RVOTs. But if the surgeon have already replaced the pulmonary with the surgical valve, bioprosthetic valve, if that is failing, that is the simplest of the procedure. We can go and put a valve in valve. I've done it and it works very well. There are different valves available, Medtronic Melody is available. Any of the balloon expander valves, we can put it in that. The most important thing with the pulmonary position is its association with the coronary artery. It is very close to the left coronary artery, sometimes to the right as well. So the only difference we do for the pulmonary is we dilate a balloon to the size of the valve we are putting on the table and do a simultaneous angiogram. If the balloon dilatation shows that you are obstructing the coronary, then don't put a percutaneous valve, send for surgery. Otherwise, it's as good as any other interventions.
Thank you.
Thank you very much, Chandraman. Your talk was extremely informative. Thank you.
Thank you, sir. I would request our panelists to hand over a token of appreciation to our speaker. Next up, we have a comparison between two topics, transcatheter aortic valve replacement versus surgical aortic valve replacement. To talk about the former, we have Professor Dr. Ajit Pillai, Head of Department, Cardiology, Kauery Hospital, Radial Road, Chennai. Sir has a phenomenally high success rate of nearly 100% in his procedures, especially the ones involving complex coronary anatomy. Please, sir.
Thank you all. Last session of the day, so I won't take much time. Let's go through the topic. So I'm not going to talk, debate with Murugan on this because I think it's just comparing apples with oranges because TAVI space is completely different from surgical AVR. I think that we discussed. The TAVI journey, we started in 2013. I think that's close to 11 years, so almost a decade experience of this wonderful technology. And it has become a very, very matured procedure. When I say that, it really means something. We have gone through the learning curves of TAVI procedure over the past 1 decade. And we now know that now we can predict the procedure outcomes in an extremely successful way. The complication rates are less than 0.1%. That means 99.9% of cases the patients do well and they get home the very next day. So this has become like a very standard coronary angioplasty procedure for us. The treatment of choice is more than 65 years. So that essentially rules out surgery, right? So you don't talk about surgical AVR in an age of above 65. If someone lives in US, I think above 65, the heart team decides for TAVI. Level of evidence 1, and that's it. So there is no debate here. The workflow for us has become very standard. Patient comes in, does a CT scan, we do analysis on the same day. Next day, patient undergoes for a TAVI. The very next day, patient goes home. That's with the workflow. So hardly 48 hours of stay in the hospital. Procedure time has been reduced to 20 to 30 minutes. So when we started TAVI in 2013, I still remember the first case. It took about 2 hours and 49 minutes, just skin to skin with a surgical cut down and all. Now it takes 20 minutes to 30 minutes. So that's how we have evolved. That's why I tell we have completely matured as far as TAVI is concerned. Supporting team has ushered up. The technicians knows what he has to do. The nurses know what they have to do. Everybody is there. And when the room was filled with 7 or 8 people, now hardly 3 or 4 us are there who just finished the procedure. So it has become extremely simple on those very frail patients who are obviously surgical non-candidates. Devices have become better. I mean, the whole workflow has been helped by the devices. We have become better and better every day, every month and every year. And that goes to show the betterment in the results. Short hospital stay, I already mentioned. Most patients getting back home next day. Drastic reduction in predictable complications. We have started treating with very sick patients, where the patient goes to the surgeon, they discuss. Now we have the heart team. We know that actually which patient goes to the surgeon and which patient goes to the interventionalist. So all the complications we have seen, and each and everything we have nailed it down to make it a very matured, predictable procedure. So that's why I tell there is a significant reduction in all the predictable complications. And I would say that today, when you compare, don't get me wrong, when you compare with surgery with a bioprosthetic valve, please understand that the surgery with a bioprosthetic valve, is it as good or even better? Please understand, this is not comparing with metallic aortic valve. surgical bioprocessing, AVR, we call it a SAVR compared with TAVR. TAVR is better. That's it. I think this is a summary slide I would like to say. Indications have expanded. As we started with more sicker, more straightforward patients, now because of growing experience, we now use it for bicuspid valve, valve-in-valve, low coronary height, heavy calcium, and smaller access vessels. So conclusion is the key to successful minimalistic TAVI, we call it as, because as I told you, two, three people are only involved in the room. It's just like takes half an hour procedure. Because as Anand was also telling, 90% of the procedure is actually in the planning. I use about 2 to 2.5 hours to work around playing around with the CT scan, seeing the patients, seeing the echo, everything. And when they take the patient into the cath lab, it just takes 20 minutes because everything is known. And just imagine there's only a 3 or 4 millimeter hole in the groin. 99% of the valves are implanted through the groin. Patient is speaking to you. It's just like a awake surgery, and you just give local anesthesia. You implant the valve, come out with a percutaneous suture and come out. There's nothing else. Okay, only local anesthesia. So to do that complex procedure with a very minimalistic incision, patient is awake, you should do that kind of a planning. So that's what. So everything is planning. What the beauty of TAVI now is actually all of us, all of the cardiologists who do valve implants have become experts in CT. None of the cardiology curriculum in the country offers CT training. But we have to learn CT to start doing TAVI. And that's the biggest, I think, advantage the structural field has taught us. So procedural efficiency, moderated sedation has become mild. Implantation technique, we have been perfected. RV versus LV pacing we'll discuss, and minimalizing complications. When we talk about TAVI a decade back, everybody was talking about complications. Now we don't tell that. It's very, very clear what we are doing. The key factor is understanding the anatomy, the CT scan, which basically looks at the aortic annulus. We come to know even those points which I didn't learn 35 years back when I was, for 40 years back when I started doing my anatomy. Now I am knowing because I am going back to, it's taking me back to the basics. So TAVI has made the cardiologists to work on their basics better to give a better result, actually. So we measure the annulus measurement, the left ventricular outflow measurements, the sinus of Valsalva, the aortic anatomy, the implantation view, and vascular anatomy. So everything is we know actually before we take the patient on board. That is a beauty. And then we make scribble actually. We scribble down on the TAVI worksheets, the hand scribble, we know what exactly is being there, what are the complications we can expect, everything is written. So when we write on your own, you know that you actually go through. It's not like they're copying and pasting to the computer. Entire team gets the game plan, allows staff to put the right equipment, leads to less waste of time. Everybody knows what they need to do. Like the technician knows when to switch on the pacemaker and to switch off the pacemaker. And it's very relevant information is only on the sheet. Everybody now goes towards moderate sedation. There is no more GF for a TAVI. Every anesthetist is there, surgeon is there, all in standby, sedation, extremely frail patients. Otherwise, everything is under local anesthesia procedure. To coordinate last 20 cases, everything is under local. And it gives much confidence. Now, after you replace the valve, you pat on the back of the patient, patient is awake, you're very comfortable. So this is basically the evolute valve. We all evolved actually. We start implanting higher by because we know that membranous septum is here. There is less degree of heart block. Heart block was one of the major problems we faced. When we started off, almost 20% of the patients, 1 in 5 patients did have ended up in pacemaker. This is again additional procedures. Now we know that we need to look at the RIO view. We need to implant it to the higher position, reduce the compression offered to the membranous septum and the AV node by the expanding metallic frame. So that's how. So each and everything we have tailored it down to get a betterment result, less hospital stay, less morbidity, and of course, less mortality. This is one thing. We started now, we understood that some of these patients develop tamponade. When we look at that, it is not because of the LV or TAVI, it's because of the temporary wire, which is actually introduced in the right ventricle. So we circumvent that by pacing through the LV wire. So there is no additional pacing lead induced RV damage. So this is again another way we matured the procedure. This is actually the dedicated system. We hope to get it next year, called the Savvy wire, which is actually the dedicated wire. You apply the pacing clips here on the red on the skin and the black on the wire, and then you start pacing, avoiding additional venous access for these patients. This is again another innovation of Solo Pace Kit. Again, a dedicated system for TAVI. Vascular access, all of us. This is again additional advantage. I mean, all the procedures in my cath lab are actually, all femoral access have been punctured with an ultrasound guidance. TAVI has taught me and the entire team to use ultrasound for all femoral punctures. I could have done closely more than 15,000 vascular punctures with the femoral, but now after TAVI protocols and TAVI procedures being done, each and every puncture, femoral puncture is being done with ultrasound. The result in the last 8 months, 0 retroperitoneal hematoma, 0 femoral bleeding, because all femoral punctures are through vascular access with ultrasound. One of my junior consultants was telling, sir, if our femoral are actually much better than radial. The last 3 hematomas documented, the patient required 1 more hospital stay for PCI, was happened on radial procedures, not on femoral procedures. That's why we nailed it actually, the ultrasound guided puncture. So again, the kudos goes to the TAVI, because we know how to manage a large bore. Now that benefit has been gone to the small bore access as well. So this I already told you how the technique to minimize the complications like pacemakers, the left bundle branch block, because conduction system, we know that it is immediately beneath the non-coronary sinus. So we can't just push it too below to push it against all the calcium in the leaflets go and hit against the conduction system to cause that conduction system damage. That's why this is learning from your mistakes, learning from the mistakes and try to avoid the complications next time. And now we have reached a stage that we can confidently take any kind of these patients. Stroke is another major complication, although it happens very rarely. Stroke is another major complication we used to see. And as we had a lecture from the Venezuela faculty, we now have a dedicated stroke prevention or the protection devices. The newer expansion, please understand, this is a newer expanding horizon for TAVR is actually aortic regurgitation, valve in valve, zero contact. Somebody who is having CKD, not on dialysis. On dialysis, it's fine because the nephrologist is going to support the dialysis. And extreme anatomies, all are now being considered. Some of the case examples I will show. This is one of the case examples very early in our experience, last decade. Patient undergoes an old core valve. None of the coronaries are flowing. Then we CPR, then this is a catastrophe actually. Majority of the patients don't do well when this happens. This is again a valve in valve case. There is no coronary flowing. Disastrous. These have all happened. We have seen all the bad things in our experience. Now we know what to be done. Or your metallic frame is going to sit in front of the coronary artery, occluding it. Now what do? We slice it. We slice the valve so that actually the coronary blood flow goes through that. So this is how the evolution of the understanding of anatomy and the processes happens. So we do commission alignment where we know that where are actually the commissions going to sit in the prosthetic valve. You see how deep the knowledge goes in, because now earlier it doesn't really matter. And for the surgeon also it's easy because he can see where is the left coronary, where is the right coronary. In a cath lab, with a minimally invasive procedure, we can't see where is it actually. So we need to emulate all these things in the CT scan, understand where is the left coronary, where is my right coronary, and then try to fix the processes in the exact location where the left coronary is coming so that my commissions are far away. You see how much the deepening of the knowledge has to happen through imaging. So this is called as commission alignment, so that the coronaries are not getting occluded. This commissional post, if it comes in front of the coronary artery, then it becomes very difficult for any future coronary intervention. Like that, the slit actually enables the interventionist to keep it open and also for future coronary interventions. How this is. So this is actually a case of degenerated coral with a valve in valve and double basilica. basilica is just like what Anand was also showing. Is actually we cut through. Actually, we through an electrically activated wire, we slit through the prosthetic leaflets so that we get a gap through which our coronary flow happens without any problem. So this is double basilica, the right cuspal aspiration and the left cuspal aspiration, and then we deploy the balloon expandable valve inside a TAVI, a 23S3 and a 26 core valve. And now you can see that actually both the coronaries, both the coronaries are actually flowing, the right and the left. This is an extremely difficult case, a valve with a very low lying coronaries. As you can see, prosthetic aortic valve. You see the right coronary artery and the left so close. If you put a valve in this, the patient is going to die on table because of the valve leaflets getting including the coronary arteries. So this is a newer technique which is called the shortcut. I was involved in this procedure when I was in Atlanta, actually. This is actually a shortcut device, which is experimental now, where actually we just like a scissor, you cut it. Just imagine like you take through the groin, take in, and you can cut it actually, just like a scissor. You see the advancements in the percutaneous ways it has happened. These are, mind you, these are extremely surgically high-risk patients. So we take a scissor-like material into the aorta and cut the leaflets in the point you want, so that actually the coronaries are actually free from occluding when the new processes is implanted. So we did, this is unsheathing of the unleashing of the shortcut, landing, cutting, and then the splitter is being activated, and then you cut it across. So that is a cutting actually, the last one which you can see on the right hand side. We call it as leaflet splitting. I think these are, I'm kind of gives me goosebumps actually, how the percutaneous ways of treating these patients have not only kind of exciting the cardiologists, but to see how much stress is adding to the innovation industry to make all these devices coming in. So this will probably replace a basilica. And then this is coming out. And then of course we put the TAVI implant post splitting, and this is the, yeah, you can see the coronaries are flowing. So this is the thing. Now, to conclude, there's another case I would like to show. This is actually zero contrast pro PCI. This gentleman had earlier had a zero contrast PCI of the middle lady on the verge of kind of dialysis. He doesn't want dialysis, high surgical risk, STS is 5.5. We did it completely under echo and actually fluorogodens with zero contrast. So this is how. So again, we need to spend more time on the CT scan. And then see, we put a lot of wires actually, cusp identification, right coronary, left coronary. These were never in our picture a decade back, because we just used to cannulate coronaries and it comes out. But then now you see, I have to replace aortic valve. Patient is in CKD, not requiring dialysis. I have to use it without a single drop of contrast. Just like we take do a zero contrast PCI, I am marking each and every sinuses, every cusp with a pigtail, multiple wires, identify and capture it in different fluoro frames, and then I deploy the valve without using the contrast. And this is actually the final result. Nothing in the aortic valve. Valve is opened well, nothing, no problem, right? So this is the last case, severe AR. Can TAVI be an option in a severe AR? This is a patient who had a previous ascending aortic aneurysm repair, who had high surgical risk, and this gentleman had a dedicated TAVI device. This is again my case in Atlanta. This gentleman had severe AR, and this comes, we did the Jenna valve. This is a CT, huge, and this is not like aortic stenosis. There is no calcium to hold on the aortic valve in processes. Please understand that in TAVI, we need calcium to hold the valve, because calcium is going to anger the TAVI's processes. So here you can see it's a huge valve actually. There is no calcium here. So we need additional anger mechanism, just like a mitral valve, native mitral. So this is what. So we just identify all the leaflets here, the non-coronary cusp, the right coronary cusp, the left coronary cusp. And because these are my landers have to come and align with this. And this is my landers coming in with the Jenna valve, the trilogy, and then comes in, the landers will fix in to the cusp. And then inside that comes in the valve actually. So this is actually a two-layered metallic processes where the locators will confirm the coronary processes, coronary locations, And this is actually the valve relief. And this is the final iotogram after the release. Excellent, excellent results. Zero AR, beautiful coronaries, no problem. I think this is also going to hit our shores sooner than later. You can see the echo, beautiful. So yes, in surgically high-risk AR patients, especially those patients who had surgery of the ascending aorta, probably yes, still I think a TAVI may work in these patients. Thank you so much for patient listening, and sorry for exceeding the time.
That was an extremely fantastic presentation. You have taken us 10 years forward, I would say. I just have a couple of questions I'm going to ask you. It may appear very elementary. See, as a surgeon, we use pericardial valves. And I believe the leaflets in your implantable valves are also made of pericardium. And we are so careful in handling those pericardial valves, even when you do an open surgical implantation. And in spite of that, these valves don't last more than 10 to 12 years. So here, this valve is crimped, it is sort of squeezed, it is then bent around in all possible angles, and then you position it, you use very high pressure to open them and all that. So how long do you think the durability of these valves are, number one? Number two, is any special techniques being used to make these valves durable? If so, why not the same thing followed in surgically implantable valves?
I think so. Edwards is working on this, sir. I'll ask the last part of the question first. Edwards is working on this dry seal Resilia technology, where they find that they reduce the risk of the degeneration. And because Edwards work on both surgical as well as things, so they are now, including the Cedric's new platform where comes there is an expandable one. They are using this technology and they're finding it great, especially with the animal models, that the degeneration is going to be far lesser. With regard to the prosthetic valve damage, I think as more and more cases we find that some of these valves do degenerate, and surveillance is very key. There are a couple of cases we have noted actually that echo was showing high gradients at 1 month review. And when we did a CT, we found that there is an attenuation in the valve leaflets. This has happened with balloon expandable leaflets. And when we anticoagulated them, they disappeared. So these, as you rightly pointed, sir, that these valves are also prone for degeneration. It's not that it's escaping from that. But so far, so good. We have not seen this as in a large scale. There have been some valves which show early degeneration. We also seen that if you are not properly, the valves are not properly deployed, the valves are pinwheeling, and especially when we post-dilate some of these valves, we have seen that the valves are getting damaged with post-dilatation. But with regard to the uncrimping of the valves or the release of the valves, so far we have not at anything. Those cases where we have found an on-table regurg, we found that there was a technical issue, which we could, luckily so far, we could address it or recognize it immediately.
Thank you, Dr. Ajit.
Thank you, sir.
I think we are just short of time. Let us go for the last talk.
Okay, thank you, sir.
Any questions you can take in the end after the talk? Dr. MSP.
Thank you, sir. Just a small token of appreciation for our speaker before we move forward. Next up, to talk about SAVR, we have Dr. R. Murugu Sundarapandyan, Senior Consultant, Cardiothoracic and Vascular Surgery, Kauery Hospital, Salem. Sir boasts about 25 years of expertise in field of cardiac surgery and has done over 5,000 adult and pediatric surgeries. Please, sir.
So, good evening, everyone. First, I want to thank the organizing team for giving an opportunity to present in this wonderful meeting. Actually, this was a good opportunity in that I could read a lot about the thing. I think more than the audience, it's the speaker who learns a lot. Most of the time we are busy operating. We don't have much time to look at literature. This gave an opportunity to look at what's going on. And as a surgeon, whenever innovations happen in interventional cardiology, we are worried we may go out of practice. So it's always a concern. There is a fear of being going out of job. So let's look at the literature. As Dr. Ajit rightly said, it's not a question of competing. It is actually both procedures are complementary. There are certain situations where TAVR is useful, and there are certain situations where surgery is useful. I think each procedure would complement each other rather than fight against each other. And good decision making by a heart team approach, I think, is the main key behind a success factor. Next. So I changed the topic, relevance of surgical AVR in the era of TAVR. So literature shows that number of TAVR procedures are rising and the number of surgical AVR procedures are actually being coming down. So in the present era, where do surgeons fit in? So this was the partner 3 results published in October 2023 in the New England Journal of Medicine, where they reported the 5-year results comparing surgery and TAVR, and they could not find any significant differences between the two. So this, you look at the exclusion criteria: bicuspid aortic valve, complex coronary artery disease, recent MACE, reduced life expectancy, comorbid valvular disease, suitable for surgical repair, significant aortopathy or an aortic aneurysm, HOCM, dense LVOT calcification, effaced sinuses of Valsalva. These were all the exclusion criteria. So obviously these are the patients who would benefit from surgery, and you exclude patients who are exclusively treated by surgery. So you are getting a very selected group, and those results don't really represent the real world situation. I'm reminded of the Stitch 1 trial where CABG was compared with CABG plus surgical ventricular restoration, and patients who were actually benefit from surgical ventricular restoration were excluded from the trial. So invariably we got an insignificant result, which is not the real world, the honest situation. So in surgery, it's reported at least 20 to 30% of patients will come back with a failed bioprosthetic valve at 15 years. This is the Western literature, and in Indian practice, we have seen that most of the valves fail by about 10 years or so. And the long-term results, I think beyond 5 years, there are no reported long-term outcomes yet to come up with regard to the transcatheter aortic valve. And there are certain specific factors like what Dr. TSK asked, like there's a lot of valve crimping, post-dilatation, implantation in a non-circular orifice, paravalvular leak, permanent, patient processes mismatch, certain factors more specific for TAVR, which can affect the long-term results. Like you said, when we implant the bioprosthetic valve, we take care not to touch the leaflets at all because we're worried about thrombus formation or damaging the valve leaflet. But here we have a valve leaflet which is crimped and released. So whether that causes any clinical thing is not yet been proved. Leaflet thrombosis is a factor which is seen even in surgical bioprosthesis. I've come across, in the intraoperatively, you find the TE shows acceptable gradients, and within a few months, you see the patient actually suddenly the gradients go up. So sometimes some of my patients, I have even put them on a low dose anticoagulation for a long time, even though the recommended, 6 to 12 week duration. So there was a article, the registry data came up, which gave a better idea of the long-term outcomes. So this one was published in 2022 in the Journal of Thoracic and Cardiovascular Surgery, which compared, these are registry data. Thing is, it's a retrospective cohort analysis. They found that up to 2 years, there is no difference, but beyond 2 years, there is a big difference in the survival curve. There's almost a 30% improved survival in the surgical AVR group as compared to the transthoracic aortic valve. Now, this is a study from Boston which compared, surgical and TAVR in the octogenarians. So anybody more than 80 is already, the life expectancy is not much. But even in them, beyond 2 years, there seemed to be a surgical advantage among surgical AVR patients. Then there are many trials reports about meta-analysis. There's a meta-analysis of all the RCTs conducted, published by the European group, and they found that again similar results. There is a reversal of hazard ratio after 24 months, which is in favor of surgical AVR. So they do a study called landmark analysis, which is a statistical method which is used to assess events at different points of time. So they divided the time period, like, the first 6 months, 2 years, and beyond 2 years. And they found that after 2 years, there is a widening of the curves. The first half, the left half, you can actually see that the curves are crossing each other after about close to 2 years. So again, we need to be little careful in recommending TAVR for patients who have a longer life expectancy, especially if they are not associated with high risk for surgery. So anatomical challenges, again, bioprosthetic aortic valve, there is a lot of asymmetry which we see as surgeons, and even in a trans TE just before surgery, it's very difficult to decipher the aortic valve anatomy. Many times a bioprosthetic valve diagnosis is made only after we open the aorta and have a look at it. There may be a single raphe, double raphe. The orifice may be in the sagittal plane or a coronal plane. Sometimes one leaflet is larger than the other leaflet. The commissure again can be in varied positions. Coronary artery can be in varied positions. So implanting a bioprosthetic valve which has got a symmetric 3 commissure is actually quite challenging, even in the surgical, even in the open surgical technique, to make sure they don't come in the way of the coronaries. So a lot of anatomical factors still, I don't think you can get it very 100% in a CT as compared to what we see directly with your eyes. CT, when there is excess calcification, knowing the anatomy can be difficult. Again, low coronary height, that is when the distance between the left coronary orifice and the annulus is less than 10 millimeters, especially if the annulus is effaced, a narrow sinotubular junction. These are all significant challenges in achieving a technical success. I think Dr. Ajit also pointed out, and he has already devised mechanisms to overcome them. Again, severe calcification in the annulus, which can extend into the mitral valve or into the posterior LV valve. All these things have a high risk of annular rupture, especially if you do and literature reports there's almost 38% of patients who actually had a severe annular calcification were excluded from the Partner 3 trial. Isolated native valve aortic regurgitation is still a challenge. A lot of experimental procedures are being done to place a valve. Since there is no anchoring, valve anchoring is a problem. Seating a TAVR valve can be a transheart valve can be difficult. In small aortic annulus, in surgery, we have the option of doing an annular enlargement and place a bigger size valve, so that when the patient comes back after 10 years, putting in an adequate size TAVR valve is useful. Whereas if a TAVR valve is done first time and a small valve is implanted, the next time when you go in for a valve in valve, you are going to put even a smaller valve, and that is going to cause more complications as well. And the need for concomitant procedures. See, many of these patients who are more than 65 years are bound to have coronary artery disease. As I showed in the exclusion criteria, patients who had significant coronary artery disease, even with syntax scores of more than 22, were excluded from the trial. So a lot of these patients who require CAVG are going to require an open surgery. And another thing which I came across in literature is once a TAVR valve is implanted, accessing the coronaries can be difficult. And some of these patients who have come with an acute coronary syndrome after a TAVR, the door to balloon time is increased, especially in patients who have STEMI. And even doing a percutaneous procedure or PCI can be more difficult. As I told earlier, patients with left main disease and multivessel disease were actually excluded from most of these trials. Concurrent valve diseases, somebody who has got a mitral valve problem suitable for a repair will probably benefited more by surgery. Then coexisting atrial fibrillation is actually again amenable to doing a surgical maze or other types of maze during surgical AVR. Pacemaker implantation is still an issue. I think a lot of improvisations are happening to reduce the incidence of permanent pacemaker implantation, because once a pacemaker is implanted, it causes RV dysfunction, cardiomyopathy, and it has been shown to reduce the survival rates in such patients. And studies have also shown that any paravalvular leak, which is more than 2+, that is in most of these TAVR trials, it's reported to be 20 to 30%. It is associated with increased mortality. Again, patient prosthesis mismatch actually shown to be higher in surgical aortic valve patients, because sometimes, patients without an aortic root enlargement, smaller valves are put in. And the definition of a PPM is all based on increased gradient. So even the baseline patients, surgical aortic valves tend to have a little higher gradient. So just want to highlight few things. On the left side, you see partner 2. In those patients, paravalvular AR was about 33.3% compared to about 6% in the surgical group. And they have reported that moderate or severe paravalvular leak after TAVR was associated with increased risk of death at 5 years. You look at partner 3, the paravalvular leak is about 20.8% compared to 3% in the surgical group. But here they have mentioned that the 5-year mortality was not significantly different. And again, I looked, the permanent pacemaker implantation was about 13.5% in the TAVR group, but it was reported to be 10% in the surgery group. I think in our practice, it is never so high. This is alarmingly high rate. I think any surgeon who has got a PPI rate of 10% should not be allowed to do aortic valve. So how this is acceptable, I am not sure. So many of these data are not presented in the main part in the, the abstract or the highlighted. You have to read between the lines to get these details. So paravalvular leaks and pacemaker implantation, which were very common, are conveniently excluded from primary outcomes or secondary outcomes, thus to produce matching results. So this is a French registry which looked at the long-term prognosis in patients who have either paravalvular leak or patient prosthesis mismatch. It was published in 2022. So they found that there was a difference in mortality, especially in patients who are followed up at 6.5 years. There was a significant difference in mortality, and there was also an increased rate of rehospitalization for heart failure in these patients. And the incidence of arrhythmia also was supposed to be high in this group. Again, we have to look at repeat procedures. We know the long-term durability of TAVR valves may not be that great. So many of these patients may require surgical AVR after they go in for TAVR. And patients who, it has been found that these patients, as compared to a straightforward surgical AVR, tend to have increased morbidity and mortality. And patients who require redo are often presenting with a median time of 2 to 3 years. About 13 to 23% of these patients actually required an aortic root replacement. So what happens is the prosthesis gets embedded into the intima. There is a neoendothelial, fibrosis and intimal hyperplasia. So the valve, the cusps get impregnated into the intima. So when you remove the valve from the aorta, you almost have to do something like an endarterectomy. And different surgeons have they have videos about different techniques, how to get this valve easily without damaging the aorta. So if the valve is implanted and you can't remove it safely, you may end up doing an aortic root replacement. So all these patients tend to have prolonged surgical times, prolonged aortic cross-clamp times, prolonged cardiopulmonary bypass time, which definitely increases the morbidity and mortality. Younger patients may develop coronary artery disease. So this is another article which was published in the Journal of American Heart Association in 2020. This is comparing patients who had a failed surgical aortic bioprosthesis, who had undergone either a redo surgery or a redo, transcatheter aortic valve. This is a multi-center. There are 2 centers in the US and another center in Germany, and they just looked at the 1-year outcome. So what I just wanted to show is, see, in the study population, certain patients who had a paravalvular leak were actually excluded from the trial. I don't know the reason. I think they wanted to match the surgical patients with the paravalvular patients. And then if you look at the median time between procedures, so a patient who had a TAVR and as compared to a patient who had a surgical AVR, the mean time for a redo procedure is 3.2 versus 10 years. That is a vast difference. And if you look at the table down, here with valve and TAVR and valve and SAVR, you can see majority of these patients, 72, within 5 to 10 years, about 72% of the patients presented even within 5 years for a redo procedure. So this is another trial published from Canada, which also says that patients who have, a redo TVR have a higher mortality. So, and again, this is a database from a multicentric trial. They have looked at, the database of patients who underwent reoperation after a transcatheter aortic valve. So you can see on the right side, the graph, majority of these patients present for surgery, the time to reoperation in months is very, very less. It's within almost 2 years. And most of these patients, when compared to normal surgical AVR, had increased morbidity and mortality. So this was the observed mortality as compared to the expected mortality was all these criteria, whether it was low risk, intermediate risk, or high risk, had significant differences. So surgical explantation of failed transcatheter valves, again, you can see in this trial, which was published from Canada, at the 1 year survival rates were hardly 67%. So almost patients who have had a successful surgery and gone home, almost 30% are dead even at 1 year. This is an article from West China, which is looking at the Asian patients. So they have compared the randomized control trials with the real world results, and they found that the RCTs actually don't represent the real world situation. Similar study has come up from the Canadian group also, which looked at results at 1 year, 3 year, and 5 years. And there was all-cause mortality was significant even at 1 year, 3 year, and 5 years. So I think the innovation and we want to have procedures which are less invasive, faster to recovery is all accepted. But whether they can produce good long-term results is still a big question mark. So the results of the randomized control trials may not reflect the real world situation. And a good heart team approach is necessary to make the patient decide on the right kind of therapy. Thank you.
That was a very exhaustive coverage of literature, Mruga Pandian, and you have brought in a lot of information about this. But only one thing strikes me, because whether these comparisons are pertinent, because originally 5 years back, 8 years back, TAVI was done only for very sick patients, patients who are not an indication for surgical aortic valve replacement. So how do they compare them? Because most of these comparisons are trials with about 5 years, 8 years duration. So how is it they have compared the patient subset as such? Because we are comparing the elderly patient on whom a TAVI has been done, who may themselves have a naturally shortened lifespan, with patients who are regular surgical replacements. Has there been any sort of standardization in how the study was done?
I think so there are different trials which look at different inclusion and exclusion criteria and try to produce the results. So if you see the initial 2 years, transcatheter valves definitely have a better, less mortality. Somebody who is not fit for surgery, if he goes for surgery, definitely is not going to survive. Whereas a transcatheter valve, if he goes for a TAVR, this acute sickness may actually become better. So at the end of 2 years, what they have found is he may actually become a low or an intermediate risk patient for surgical AVR. So unless you survive the initial 2 years, you may not be alive after 2 years. So there's a lot of mix-up, the overlap between different patients. So that is where I think a good heart team, a cardiologist and a surgeon is to look at, and individual, all these things have to be decided and taken up.
Exactly. See, that's why I asked this question, because they have primarily compared mortality in most of these studies.
Correct.
Not the other issues. So I think in my opinion, both the procedures are going to be there to stay. There are going to be very specific indications where they are going to do it. And once technology advances, probably once they have better hardware and better ways of assessing the valves, probably they'll be doing more and more younger patients. Probably that is a time when we can actually compare the results of surgical versus
I think the procedural wise, the technique wise, we have there is a good excellence. I mean, they are able to achieve almost close to 100% technical success. But the question is whether the valve leaflets can be durable for a long time is still the open to research. So if you are able to get some material which can last for a long time, and if you can have a valve without undergoing an open heart surgery, I think that will be the best deal.
I think they have already come up with a flexible artificial leaflet, which they say can last as long as the metallic leaflets what you're putting. I'm not sure. Maybe Dr. Ajit can enlighten us on that.
Now no one tells about PCI versus CABG. As far as TAVR is concerned, the interesting note is actually when we started doing PCA, we were starting with the simplest of the cases and then gone on and operating those left mains or CTOs and all. As with regard to TAVI, we started off with the sicker patients, more sicker. I remember the first few cases of TAVI were extremely frail patients. We never thought that even they survived TAVI. But now we are operating on relatively kind of stable, relatively younger. Like we used to take 75 plus. Now it has come to 65 plus. So when I understand, like Sir was telling, it's very difficult to draw a parallel between these things. Now I was listening to that valve in TAVR and valve in SAVR patients. The valve in SAVR patients, the SAVR patient when it fails, it will be again SAVR in SAVR only, not TAVR in SAVR. When he goes to a TAVR, that means he's already surgically sick. So that 10 years gap is probably biased by the fact that those earlier patients would definitely go for will not come into this trial because they would again go for a repeat surgery rather than only when the heart team decides that no, he's too sick for a surgery, will come forever. Now, to conclude, I feel that, sir, I think both techniques are going to be stay together. Guidelines are guidelines. For individual patients, I think it's just like we need to discuss individual patients actually, which is the best treatment to go. The technologies are going to be improving. Like now, I know that surgeons are also looking at the CT. Earlier, I think they just take patients on echo. But they are also becoming more thing. With smaller annulus, I think more surgeons are now opening for aortic root enlargement. That's also a welcome sign. Because whether it's surgical or it's TAVI, both we know that actually smaller annuli is actually a big Achilles heel. We don't get good durable gradient directions. So I think each of us will have to take kind of lessons from each other. And technologies will go forward. When we come to the commercial part, I would say that actually that more money is going to be pumped into transcatheter because obviously they are more expensive. Most of our baselines are coming from the United States. Obviously, it is a company-driven, industry-driven country. So when I last visited New York, I found that almost like in the New York province, almost 50% of the surgeons are actually doing TAVI because they get more money out of TAVI than SAVI. So I know these things are apart, but what I understand is actually minimally positive sides of both. Thank you.
Thank you very much, Dr. Ajit. Before we conclude, we have a very senior cardiac surgeon with us, Dr. Raghuram, who has got a vast experience in surgical aortic valve replacement. I would like his views on this debate.
Well, hearing through both the lectures, I thought initially the question put was, which is better for general population? That is what was the question, at least I understood like that. My own impression is that in very high risk patients, TAVR scores over SAVR. TAVR is the way to go because they will not stand a surgical aortic valve replacement. If patients with high risk only were taken for TAVR, this debate would not have been required at all. But now what is happening over a period of time, the TAVR is being extended to moderate risk and low risk patients. And that is exactly why this debate is coming up. There is absolutely no challenge that in high risk patients, TAVR is the way to go. But is it right to extend it to the moderate risk and low risk patients? And all the studies that he quoted, most of them were only comparing patients with moderate risk and low risk. And when you follow them up for an adequate period, you find there is a gross difference in survival, quality of life, and readmission for hospitalization with respect to TAVR compared to SAVR. That is exactly what I wanted to emphasize. What the first lecture by Dr. Ajit Pillai was a lecture on the future possibilities. There are excellent ways to tide over the problems when we want to tackle a high-risk patient. The way he is cutting the leaflets so that he gets a coronary access, the way he is able to treat a very sick aortic regurgitation patients, they are all meant for high-risk patients. But when he started in his first 2-3 minutes, he said, in America today, anybody over 65 years is a candidate for transcatheter aortic valve replacement. That, I thought, is an overstatement. So I personally feel surgical AVR is the way to go for all patients in low risk and medium risk. For high risk, without any doubt, it is TAVR.
Thank you very much, Dr. Raghu. I think we had an excellent discussions. I think we'll conclude the session with this.
I request the panelists to give a token of appreciation to our speaker. I now invite upon stage Dr. Lieutenant Colonel Mahendra Kumar Sir, Medical Administrator, Kauery Hospital's Marathalli branch, to give a token of appreciation to our panelists.
Thank you, sir. With this, we come to the end of today's session. Thank you everyone for your presence, patience, and participation. We will meet here tomorrow, 9 a.m. sharp. Dinner is arranged. Please proceed to the dining hall. Our organizers will help you with the direction. Thank you.